C'est vrai. Àwọn èèyàn ti ń pariwo lórí platform pé kí ló dé tí wọ́n admit àwọn ní.
Just no problem. Just me mountain. A damnation for the name divine the form. The name of Jesus is higher than them all. The name of Jesus is above all the name. Just no problem or any mountain. No damnation, no the name they bow they fall. The name of Jesus is higher than them all.
Church or workshop. Man, my facilitator. No glove now. If you know you are very sensitive.
Lord Jesus is higher than the world. The name of Jesus is above all the name. Just name a problem or any mountain.
Good morning, everyone. Please mute your mic, please. Thank you. No. Mama, if you continue, I won't hear what they are saying. Stop. No. Okay, if there's any problem. No, not my work. That one is not. But is it where I'm supposed to listen to this program? I'm not supposed to be in the house. You read anything. Oh yeah, are you feeling it?
That's how I this is really interesting.
I mean, I can't figure it out. They want us to ask. They don't want us to ask. They want us to make a move, not make a move. They want us to be on the bottom. They want us to be on top. Use hair products. Don't use hair products. What do you people want? But you have to promise not to say it. I swear. Because it's a secret. I'm sick. No idea.
But me too, that will give.
Come back here. The host has not muted. The background is noisy. They have not started. The host is supposed to mute everybody.
Let me do it. I'm leaving the
Maybe I should go and carry your stuff. Then I move that nonsense like that. I don't want to see you again on the floor there.
Can't collect what I'm doing.
Lower it too. Lower it. Lower that thing now.
Okay. Okay, so you can. Alamin juya ta ko. Ka juyo aka ce alamin. Kuma can ji
Hello, good morning.
Who is going to introduce? Samani?
Good morning, Professor. Good morning, participants. You are all welcome, and we are sorry for starting late. So, without wasting much time, I'll hand over to Prof to start. Welcome, sir. You can start.
Okay. Good morning, distinguished colleagues. We are sorry for keeping you waiting, and it was due to little glitches we had regarding our laptop. We have to change the laptop to another one. Please accept our apology. And before I go in, I want to thank everybody for joining this. And I hope at the end of the day, we are going to learn one or two things regarding assessment of musculoskeletal disorders. I am Mukadas Akindele. I'm from Department of Physiotherapy by University Kano. And I'm presenting this at the instance of invitation from Bray Physiotherapy and Medical Rehabilitation Institute. Can you please mute our phone? Is that okay? Yeah. Few of the objectives are Secondly, we are going to describe the tests, so various steps we take in carrying out subjective assessments. And the number 3 is going to be, what are the techniques you can use for provocative tests for musculoskeletal disorders. And the next one is going to be, what are the imaging assessment you can prescribe, you can ask our patient to do to arrive at a very good diagnosis for musculoskeletal disorders. Now, I want us to have one or two rules. The first rule is that I want to advise us to mute our microphone so that there won't be distraction. The second rule is, at interval, I pause a bit to ask for whether there's any questions from my presentation or not. And if you have any questions or have any contribution, you can always raise our hand to show that. So, what are the aims of carrying out subjective assessment? If you go through what I said earlier regarding the objective of this presentation, really mention something on the aims of objective assessment. It was intentional because I'm going to assessment. Number one, we carry out objective assessments in order to gather relevant information. Number two, we also carry out subjective assessments so as to review. Subjective assessment is carried out.
So now opposite side Camilo zongo one kiosk never. Akoko under the GP all this road that man. Now beside the only one bachaya forever back at the one. Is an able the boy shall be some of one point like that black for. If I can name more for good food.
So let's please, sorry for the glitch. Now I want to define subjective assessment as the personal experiences. Can you please mute your phone? I want us to define subjective assessment as the personal experiences, the personal views or feelings of the patient. Nwachuku, please mute your microphone. Or feelings of the patient.
Don't think no way book never know it. Let's look on one for treatment. Apart from that.
Can you mute them?
Sam, mute her from there. I don't think she's hearing you.
Yes, are you mute her? Thank you. The organizer is going to do that. Okay, so I want to define personal subjective assessment as the patient's personal experiences, patient views and feeling regarding the ailments or the experiences relayed by someone close to them. Regarding number one, the chief complaint of the patient. Chief complaint in the sense regarding the symptoms, the conditions of the patient, and the previous diagnosis that the patient has had. And when we want to get the subjective assessment of the patient, it's better we allow the patient to state all our feelings, all our problems. If a patient is telling us his problem, it's not advisable for us to interject by telling us what the problem is. On that subjective assessment, one of the few things we do is to look into the history of the present illness. And there's an acronym which is called OLD-CARTS. OLD-CARTS, which is OLD-CARTS. O stands for the onset. We want to know when and how the chief complaint starts. Secondly, location, we have to know where is the location of the chief complaint, the duration, how long has the chief complaint been going on. C stands for the characterization of the chief complaint. How does the patient describe the chief complaint? A stands for alleviating and aggravating factors. We want to know what are those steps that give the patient relief, and what are those steps, what are those things that the patient does that makes the patient pay or problem worse. The next one, which stands for R, is a radiation of the problem. We want to find out whether from the patient, whether there's any radiation of the symptom, whether from the source to other part of the body. And T stands for temporal factor. Severity, how symptoms. Now, let's quickly run through this. I'm not going to waste more of our time on that. We go through past medical history of the patient, in which we look into the kind of drugs the patient is taking, whether the patient had any surgical history, the family history of the patient, the social history, as well as review of the systems. This includes general health of the patient, the weight loss, look at the GIT of the patient. Is there any issue of abdominal pain? Issue of the musculoskeletal problem of the patient, any toe pain, any decreased range of motion in any of the joints in the body, as well as what are the allergies the patient has had regarding taking some medications. Are there medications that the patient is taking that are interfere with physiotherapy we are going to render for the patient, or the treatment we are going to render to the patient? Now, if you want to carry out physical examination, physical assessment, I've arranged the step I think we should follow. This is not exhaustive anyway, and it doesn't mean each of the steps should be followed in total one by one. So the first thing I will do is to observe the patient, observe the patient, followed by inspection of the patient. And now go on to carry out selective tissue tension tests, as well as neuromuscular tests. Next, is going to be palpation of the patient, provocative tests. The next one is going to be special tests. Then I go to functional assessment of the patient, then imaging. So let's start with observation of the patient. We're going to connect automatically.
Which one is audio? Me, I'm not seeing video if I'm saying audio.
Oh, yeah, it's okay. It's okay. It's okay.
Mr. Mr. Arrow, please mute your mic.
Okay, sorry, we have to change the source of our internet so as to avoid further glitches. Okay. Yeah. Under observation, I want us to look at the general appearance of the body of the patient and the patient general body build. I want to know whether is patient slim, is he obese, is he muscular, is he emaciated, is he tall or short? Then we also want to have a look at the posture of the patient. Is there any deviation in the normal posture of the patient? Is there any lordosis from the patient? Any feature of flat back? Any scoliosis? Any kyphosis? Any kyphoscoliosis? Is there any sign of sway back? And I want to say that the best time to observe the patient general appearance and functional status is when the patient walks into the treatment room. When the patient is undressing, or when the patient is under examination, or when the patient is under treatment. It's better for us to stand at the entrance of the treatment cubicle to observe our patient walks in. Whenever I want to see a patient. Then we also want to look at the gaits of the patient. Is there any compensative movements while the patient is walking into the treatment cubicle? Is there any guarding movement that the patient is trying to carry out? Patient is trying to avoid putting weight on certain part of the body because of pain. Is the patient using any walking aids or not, or any assistive devices? You have to take note of all this under observation. Now, under inspection. How do I move scale now? Under inspection, I divide this one into 3 sections. The bony structure and alignment, the subcutaneous soft tissue, and the skin and the nails. We have to observe all this. Under bony structure and alignment, we have to look at the tubercles, navicular tubercles. We compare the fibular heads for both lower limbs. We check the patellar borders. We assess the greater trochanter of the patient, both right and left. We also look into the scapular borders. to compare the right and the left and find out which one is not appropriately placed. Now, the next inspection we should do. Is to inspect the subcutaneous soft tissue.
Please, those people should unmute their mic now.
We have to palpate under subcutaneous soft tissue. We have to palpate the soft tissue. We have to look by looking for swelling, any edema, any atrophy of the muscles. Are there any abnormal contours in the patient body? Those are the things we look out for under soft tissue. And we also look out for, is there any changes in the temperature of the body by palpating, by using the back of our hand to check whether there's any differences, there are any differences in the temperature between the affected side of the patient and the non-affected side of the patient. And the next thing we should inspect is the skin and nails of the patient. Under this, we have to look out for whether there are any changes in the color of the skin and nail, whether there's any change in the texture and moisture of the skin, and are there any presence of local scars in the patient body, any blemishes that are visible? Does the patient have any open wound in the parts we have been examined, as well as are there any localized skin abnormalities that the patient has on his or her body? Still under inspection, I'd like us to have a look at the posture of the patient. We want to look at the posture of the patient. This assessment should be done in standing, actually in a weight-bearing position for the patient. Actually, when the patient is walking into your cubicle, or after the patient might have undressed, you have the patient to take a few steps forward and backward and have a look at the posture of the patient regarding whether there's any scoliosis, any abnormal curvature on the back, and anything that is not appropriate to the normal body configuration. Now, under inspection, for us to have a guideline, we can use a plumb line to assess the posture of our patient. We can use these are the bony landmarks we can use for the plumb line. We can use mental protuberance of the mandible for the anterior view, and for the anterior view of the patient, we can use external occipital protuberance for the posterior view of the patient. And anything we do, it's better we compare our findings with either the unaffected side or finding from the previous experiences we had. The next thing we should measure is the muscle guard, the extremity guards. Measure the extremity guards for atrophy, for hypertrophy, for edema, or for any swelling. How we are going to carry these ones out will be discussed later during the course of this presentation. Now, still under inspection, part of what I said earlier was to look out for swelling or edema. We all know that in the body, soft tissue edema can occur in a patient. Now, and when it occurs, usually come with either it's heated or not. It might be painful. There may be skin discoloration, there may be changing the color of the skin, and there may be changes in the temperature of the skin. And whatever any part of the body we are assessing, the better we'll compare it with the unaffected side. And for us to assess edema on any part of the body, we can use any of these volume measurement, in which let's use one of the extremities, maybe the lower limb. If there's edema on the right foot, we can immerse that foot on already measured water and find out whether there's any increase in the volume once the patient dips the limb in the water and compare with the unaffected side. You can also use the gap measurement, like I said earlier. Under the gap measurement, you can use circumferential measurement which we all know how to do. We can also use figure of 8 method. This one is being used to assess whether there's any edema in the upper limb. And this is how it's done. This is the figure. This is how it's done. Can we see my cursor moving? This is how it's done. Let me see how it looks like. How does it look like? Can we see it? The figure of 8 method for assessment of hand edema. This is how it's done. Okay.
Hello, sorry, the image is too tiny, We cannot see it very well.
Okay. Maybe I should demonstrate it. We have a tape measure. Will you mind if I show how we do it? How it's done?
Yes, sir. Yes, sir. You can show us.
Okay, let me just. Can you see my hand, please?
No, it's just the screen that is showing.
My hand? I want to know whether my camera is okay or not.
Yes,
can we see
you
my
can
hand? Okay. Now,
No.
I'm going to stand up and use one of my colleagues here. Can I use your left hand? Can you see his hand?
No, we cannot see you, sir.
Out of now?
Yes, yes.
Okay. Now, we said we use figure of eight method to assess the edema in the hand. You can only do what, man?
I can see it now.
Okay. Now,
It's
this is the
off
tape
and
measure we are using.
It's off and on.
It's network.
Sir, it's going on and
Can
off,
I?
sir.
Please, we can't see you, sir. We can't see your hand anymore.
Okay. Sorry, will you mind if I send the video at the end of this presentation?
We can see you now.
Better. Just send the video after.
Yes, the video is better.
Wasting time.
Okay, I send the video to Ray. So they are going to send the video to you at the end of this presentation. So in order for us to assess the edema of hand, we use figure of eight method, which I'm going to send the video later. I'm sorry that the figure I presented is too small. It's not so visible. Now, edema assessment. Okay. So, edema assessment, we know there are two types of edema. It's either it is pitted or not pitted. Now, we want to assess it. We have to find out whether the edema we want to assess in the limb, either upper limb or lower limb, whether it's pitted. So, as I was saying, when we are checking for edema, we check for whether it's pitted or not. We check whether there's any tenderness after while palpating it. If there's any tenderness while palpating edema, we have to put our mind on whether there's any DVT, that's deep venous thrombosis in that area, or whether there's any signs of complex regional pain syndrome. We also check the skin temperature, whether it's warm to touch check the skin color and the texture. If the area being examined is warm to touch, they're actually associated with cellulitis or DVT. DVT, deep venous thrombosis. Also, we also look for redness, in the skin. I want us to look into assessing those of us who have dark skin. Do we see redness in our skin? If there's a problem with our skin, can someone please help us out? I'm not referring to those who are of light complexion. What do you see in a dark-skinned man with redness on his skin or her skin? What do you observe? Colleagues?
Purple.
Purple? That's extreme. That's very, very extreme. There will be increased darkness. There will be increase in darkness in that area. So we look for redness of the skin. Is the skin shining? Or is there any ulcer there? You have to take note of all this. Also, we have to look out for yellow brown. This internet is unstable. Does the skin look yellowish brownish, which is a sign of venous insufficiency? Now, still under inspection, we have to look out for joint effusion. We all know that we have effusion in the joint when there's presence of excess fluid. And this can result from injury to the joint, infection to the joint, or any other medical condition. Joint effusion caused by injury to a joint, infection to a joint, or some any other medical conditions that we might not discuss here. And if you want to assess the joint effusion, either we use joint fluid analysis, in which you are going to take a sample of the content of the joint of the effusion and send it to the lab. You can use imaging. Send the patient for imaging, might be X-ray, might be CT scan, might be MRI. Depends on what a patient can afford. Also do physical tests. I'm using knee as an example. Also use physical tests. One of the physical tests we use for joint effusion is bulge, wipe, or stroke test, or fluid displacement test. I'm going to show the video how it's done, as well as patellar tap. This is the video. Is this showing video? Is this showing? This showing? No. I'm supposed to show the figure. It's not showing. Yeah. The network is not so good. I'm supposed to be showing the video. Like the video now. Yes, that guy.
Prof, let's go ahead. If the video is not showing, let's go ahead.
Okay. I'm sorry. So at the end of the something, I'm going to send the video to. Now, this video will show us how to carry out fluid displacement test and patellar tap. We can use to determine whether there is any effusion in the knee joint. The one I'm showing is just for the knee joint. There are many different tests. There are different tests for each of the joints in the body. Now, still under inspection, we have to check the muscle spasm, muscle guarding, and protective splitting. Muscle spasm, we all know it. Don't let us dwell more time on that. Muscle guarding, we all know it. Protective splitting, we all know it. Now we have to palpate for soft tissue tenderness, whether there's any flexibility and density. We have to examine the joint line tenderness. Let's take one of the knee as an example. When we palpate, deep palpation to the knee joint, look at we palpate the space between the femur and the end of tibia. We palpate deep palpation to find out whether there's any tenderness or not, whether there's any masses, or not. And we also look for presence of swelling. As we are doing all this, we have to be comparing the area being examined to the unaffected area. Now, what we said earlier, they were all under selective tissue tension test. Under this, we'll be making use of active exercises, that is the active range of motion, that's the motion the patient can perform on his own own, passive movement, as well as resisted movements. So those are the three areas we are going to cover under selective tissue tension test. Now, for active movements, okay. While the patient is carrying out the movements, you have to take note of the patient account of pain. Why patient, let's say we ask the patient to flex the elbow. Does the patient give any account of pain while carrying out the active movement? We have to take note of that. And we have to take note of whether there's any painful arc movement. Why carry out the movement? Why carry out the range of the movement in the joint? Now, if there's a pain tolerance, like when you ask your patient to do range SLR, it means there's a problem with enough foot. It means you have been stretched enough foot. When you ask your patient to carry out the movement
a little bit.
Excuse me?
Could you kindly remove your screen from the presenter's view to at least enlarge the content? Thank you.
Are you see the presenter view too?
Yes, on my side, I'm seeing the presenter.
We have.
It's not supposed to be seen.
Kindly enlarge.
As of now, I didn't close it. Is this one okay?
We can't view your screen again. No, all your screen is go. Okay, we can now. We can.
This one is better, Professor.
Yeah,
Okay.
it's better now.
Now, active movement, we ask our patient to carry out, depending on the joint that is under examination, to carry out active movement. And while the patient is carrying out this, we take note of the pain that the patient complains of. if there's presence of pain, why carry out the movement, especially in an act, if there's an act, painful act of movement, it means that there's something that's being irritated. Now, let's look at an example of straight leg raising we ask our patient to do. The patient complains of while lifting up the lower limb in supine position. It means the patient is being pulled, there's a problem with this protrusion. If the patient complains of pain during straight leg raising. Or, let's take shoulder as an example. You ask your patient to move the shoulder joint, either to abduction, to elevation. And the patient tells you that from so degree to this angle, there's no pain, but from this area to this area, there's pain. It means that something is being impinged, or there's an inflammation of the tendon in that area that is being moved. Now, please, I want us to take note of this. Any range of motion the patient is able to carry out should be measured objectively. And we all know various means through which we measure the range of motion in our patient joints. And the most easily used one is use of goniometry, which I don't think is far below this kind of presentation. Now, while the patient is carrying out the treatment, the movement, the active movement, you need to take note of whether there's any crepitors. Let's take example of a knee joint. I prefer for my patient to carry out active movement in weight-bearing position. Actually, I ask my patient to climb or descend a staircase. So while my patient is doing this, I look for the crepitors. I look for whether the patient is trying to dodge putting weights on the affected side. I look for whether there is any swelling. I look for whether there's any, if I thought there's swelling, is there any changes in the direction of the swelling while ascending and descending the staircase? So please, let's take note of all this. Now, I say under selective tissue tension technique, we're going to talk about active movement and passive movement. Now, under passive movements, these are the movements we are going to carry out on the patient as an examiner, as a physical therapist. Under this, I divide this into two. We want to look at the type of restriction we have, whether the restriction is caused from the problem inside the capsule of the joint, or whether the restriction the patient is having in moving that joint is outside the capsule of the joint. The first one I talked about is called capsular pattern of joint restriction. Capsular patterns of joint restriction. Now, this refers to the loss of mobility of the entire joint capsule, which might be from maybe fibrosis, effusion, or inflammation. And it is worthy to say that it is only joints that are being supplied, that are being moved by muscle, that can have capsular pattern of joint restriction. Let me say it again. We have capsular pattern of joint restriction in the joints that are being moved by muscles. It means joints that are not under movement might not have capsular pattern of joint restriction. Do I repeat it, colleagues? So, now, like I said earlier, capsular pattern of joint restriction can result from arthritis or degenerative joint diseases like fibrosis or inflammation or effusion, or it can also result from prolonged immobilization, like after fracture or whatever, you put your patient on a POP cast. Can result in capsular pattern of joint restriction. Or it can also result from acute trauma to a joint when you have a fusion. And like I said earlier, each joint that is under muscular control have capsular pattern of joint restriction. And the funny thing is that the capsular pattern of joint restriction you have in the shoulder is quite different from the one you have on the hip, or on the elbow, or on the wrist. The type of capsular pattern of joint restriction you have on the hip is quite different from that you have on the knee or the ankle. So each joint have their peculiar capsular pattern of joint restriction. Now, for the non-capsular pattern of joint restriction, these are the restrictions that occurs from mechanical blockage or extra-articular lesions. Mechanical blockage like capsular adhesion or tear of ligament that is inside the joint, that's under internal derangement, like extra-articular tightness, so something like myositis ossificans, or something like acute bursitis. All these fall under non-capsular pattern of joint restriction. Now, still under passive movement. Now, we have to test. Remember, I want us to remember that we are the one carrying out the passive movement now. We've noted the kind of, when we move the joint, what type of restriction do we have there? Is it capsular pattern or non-capsular pattern? Now, we also want to know, how does the patient feel towards the end of the ROM, passive ROM, which is what I refer to as M-feel. M-feel is a type of sensation or feeling that you physical therapists experience when the joint under investigation is being moved. When the joint under assessment is being moved, you are the one to experience this. You are the one to experience capsular pattern of joint limitation or non-capsular pattern. So, and there are many different types of M-feels. We have normal M-feels, we have pathological M-feels. Now, under normal M-field, we have capsular M-field, we have ligamentous M-field, we have bony M-fields, we have soft tissue M-field, and we have muscular M-field. All these are normal M-field. Muscular M-field is like what your parent experiences when you're asking to do straight leg raising, and when you are trying to assess your patient for hamstring tightness. That's the kind of feeling you're going to feel your patient have tightness of the hamstring. The patient won't be able to complete straight leg raising more than 60 to 70 degrees unless he or she flexes the knee. Now, soft tissue approximation, this one is the one in which you have when you flex the patient's elbow or hip or knee, sorry, the movement is being stopped because of the contacts of the soft tissue. And the bone M-field is one in which the movement is stopped because of the approximation of the bone. Like, let's take example of elbow extension or knee extension. So those are the normal M-fields. Anything that is not within this 4 or 5, you fall under abnormal M-field. Now, under abnormal M-field, we have muscle spasm M-field. Sorry, it's N-field, not it's N-field, not M-field. I'm sorry for that spelling something. Now, under this, the movement is stopped abruptly because of the muscle contracting reflexly, usually seen in upper motor neuron lesion. We have capsular abnormal M-field. This one is similar to tissue stretch, but usually seen it when there's reduced ROM. Capsular M-field, the abnormal one can either be hard or soft. Under capsular hard capsular M-field, the quality and limitation just stop immediately. But for the soft one, the stoppage is gradual and usually results from acute condition. We also have boggy M-field. This results from a joint effusion like we have in the joint, in the knee joint. usually seen in knee joint, any joint where we have joint and fusion, either knee or elbow or hip. You usually see boggy end field. And the empty end field is the one in which you keep on moving the joint, no restriction. But when you get to a certain stage, the patient begs you to stop the movement. This might result from acute bursitis or joint inflammation or recent fractures. But this is not advisable anyway to move a joint, a fracture bone that has not been reduced. Now, under selective tissue tension test, the last thing we are going to be talking about is the resisted isometric test. Resisted isometric test. Under this, we are going to grade, we are supposed to grade the kind of resistance we have when we move our patient joints. And we should assess the status of the musculotendinous tissue. When we carry out the movement, it's either the movement is strong and painless. If the movement, if the resistance to the movement is strong and painless, it means there is no any musculoskeletal lesion, no neurologic deficit, no problem with the muscle or tendon on the nerve in that region. If the movement is strong and painful, it means there's a minor lesion of the tendon on that test. Or muscle, there's a small tear on the muscle. If the movement is strong and painful, the lesion there is minor, and it might be from the tendon or from the muscles. If the resistance is weak and painless, it means that there's problem with the nerve to the muscle being tested. And it might even be that there's complete rupture of the tendon or complete tear of the muscle. If you're trying to move, you ask your patient to resist. Resistance to that procedure is weak. The patient cannot resist. And the patient tells you that he or she is not even feeling pain. It means there's problem with the nerve supplied to the muscle in that area. Or the tendon of the muscles there has been ruptured, or the muscle has been torn. And the last one is weak and painful. If the results, if while moving that body part, patient tells you that you observe that the movement is weak and the patient complains of pain, there may be partial rupture of the muscle, of the tendon, or tear of the muscle, but these things are still intact. Or it might result from painful inhibition, that's like fracture, or neoplasm, or acute inflammatory system going on in that area. So those are the few things regarding resisted isometric test. Now, it's still part of our duty to carry out some neuromuscular tests. Under this, I want us to look at the strength of the muscles, the strength test, deep tendon reflexes, as well as just three of them: the strength of the muscles, the strength test, and deep tendon reflexes. Now, when we want to test the muscle strength, better we use the precision muscle testing we use, which are Oxford muscle grading. And while carrying it out, we don't assess it, we don't carry out the test once. It's better we do it twice or thrice and compare our findings with the unaffected side. Now, we also have to take note of the weakness in the muscle. Is there any asymmetries in the strength of the muscle? And it's not, if a patient comes with a complaint of pain of the upper limb, it's advisable for us to assess each of the muscles that we have in the upper limb, not just assess just only one part, just only one joint, just only maybe muscle that supply the elbow. It's always advisable for us to assess each of the muscles that form upper limb musculature. And this is going to give us a clear idea of where our patient problem is. Now, the second one is the sensory test. These are all what we've been doing: use of pin, width of cutting, tuning fork, to assess the conduction along the sensory pathways. We also need to assess the corresponding parts that are not affected. The last one under this, under the muscular test, the deep tendon reflexes. We have to take note of whether there are any reduction in the deep tendon, which might result from upper motor neuron lesion, sorry, lower motor neuron problem. And we also have to take note of whether the reflexes are hyporeflexia or hyperreflexia or normal. So we have to take note of all this. Okay. Can we give ourselves 30 seconds to disengage our ischial tuberosities for those of us who are sitting down? And those of us who are standing, can we just engage our ischial tuberosity for 30 seconds? I've disengaged my own ischial tuberosities because I've been sitting. I'm going to leave the couch. Which one is strong? But I'll let us to carry out. We have to let it ready. When we are ready, we can move it here. But don't move it now because of you. So let's go back. I want to engage my ischial tuberosities now. Now, provocative tests. These are the tests we carry out to reproduce the patient pain, to reproduce the patient chief complaints. In musculoskeletal disorder care or treatment, 80% of the complaint is pain. So I want us to go through the tests we can carry out to reproduce that pain. Number one, you can use gentle passive overpressure at the end of active or passive movement. You ask your patient to flex. Patient comes with a complaint of pain in the elbow, and you ask your patient to flex the elbow. And when the patient flexes the elbow and they get to certain degree that the patient cannot go further, you can apply overpressure so that the patient, you have to know whether that overpressure gives the patient pain or no pain. Or you can passively move the patient elbow. When the patient tells that the pain has started, you can apply a bit of overpressure to find out whether the overpressure you are applying increases the pain or reduces the pain, or the pain does not change at all. Number two, it's advisable for us to carry repeated movements at various speeds with sustained pressure. We ask your patient to carry out active movements gently. Now ask your patient to increase the movement, the speed of movement, while you are sustaining the pressure. Number three, you can carry out combination of movement in a joint, which they call quadrant test. Quadrant test. We are going to show that one later, actually for the hip, how it's carried out. So we can carry out this as a form of provocative test. Now, for the hip, to carry out the provocative test, I'm going to use quadrant test. That's a name they call it, which I've forgotten. I'm going to remember later. Can we have the couch? Sorry, I want us to demonstrate this. Can you have the couch? Hmm. So that it will be visible. Can you see it? Can you see the couch? Please take your phone. I want you to take the phone where I can see the couch. Can you see the couch? Out of now? Can you see yourself? Out of now? You can see the couch. See, can you stand there? Can you see him there? Out of now?
Yes, we can see the couch now. It's
And can
green
you see the
in
guy
color.
standing? Okay, and the guy standing there?
Yeah, we can see
Can
him
you-
holding a phone.
Excuse me?
Yes.
You can see, okay,
But
who is going to land the
if
couch?
you can,
But the
if
what?
you can put on the light there, sir. If there is light there, if you can put it on, sir.
The light is on. Actually, there are about 3 bulbs there.
Okay. But we can
I
see
have
the
3
couch
bulbs there.
now.
Okay, please. Can you please see me?
Yes,
Yes,
sir.
we can see you.
Thank you very much. I'm standing on the right side of the patient. I'm moving towards the patient's right lower limb, sorry. So I'm going to flex the patient's hip and knee. Just okay, relax. I'm going to flex the patient's hip and knee to 90 degrees. So what I want to do is to call it quadrant. I'm going to rotate in, and come out. Then put the hip in extension, something like this, and find out what the patient feels. I can even go the other way. So this is for the hip. There's a different something for the shoulder, the quadrant. So that's for the shoulder. That's for communicative test for the knee. Sorry, for the hip. So the unaffected side, the hip and the lower back for examination now, because literature have shown that the chief complaint areas that patients have are the hip and the lower back. And subsequent slides towards the end of this presentation, our examination will be focused on assessment of the hip and assessment of the lower back, for lower back pain and for the hip pain. Now, for the contract test for the lower back, you can please get that. So how to do the contract test for the lumbar region? You are going to ask the patient to stand. Contact. Let him get down. How do you get down? How do you say get down? So they are doing things for him to expose his back. Please, can you please see us? Does he have a singlet on that? Yes. Okay.
No.
Can you see my friend? Can you see him?
Yes. You can see him, sir.
So
Yes, we can see him.
these are subjects. And I've joined him. So I'm going to ask him to side flex, supporting in here. This then rotates to just stand up straight. Ask him not to bend his knee. Okay. Keep your knee straight. This go. I'm using my hand to stabilize the hip because I want the pressure to fall on the lower lumbar. The examination. So we are going to start with side flexion like this. Just bend to your side. Like that. Now we stabilize this, then move the patient back, rotating towards you. Relax. So that the movement will fall just under on the lower back. Want to put pressure on the nerve. Want to make the nerve in the lower back region, especially on the right side that have been examined. Want the nerve to be angry. Want to provocate the nerve so that the pain will be reproduced. So that's for the lower back. Okay, special tests. Special tests depend on the nature of the patient's stiff complaint. The symptom being, you can see that the symptom being presented, as well as prior physical examination results. There are usually 3 types of special tests. It might be joint and ligamental tests. We are going to do that later. Neuromuscular tests, we'll discuss that, and neurologic tests. Okay. While assessing our patients, part of what we should do is to assess the to carry out the functional assessment. This can be used. This can be done using questionnaire. Few of the questionnaire we use is what they call Bartel Index. The next one is a functional independence measure, which is for the adult. And the third one is functional independent measure for children, which is called WIFIM. So we have to assess our patient functional performance using any of these questionnaire. You can also use functional performance. You can ask our patient to do some function. One of which is time up and go test or 6-minute walk-up test. These can be used to assess how our patients are functioning regarding their problem. And the last one there is to assess the health-related quality of life for our patient using some questionnaires too, like SF12, Eurocall 5 domain, as well as WHO quality of life questionnaire. You can use all this to document the functional assessment of our patient. Now, imaging. Most of the time, anytime when we examine our patients, at the end of the day, we usually ask them to go for either X-ray, MRI, CT scan, anyone that a patient can afford. So, few of the things like we should ask our patient to do is a X-ray, which is digital radiography, or CT scan. For CT scan, the density of the body tissue. Any problem? For CT scan, the more dense a body tissue is, the more X-ray absorbs. And let's take a bone as an example. Bone is a dense tissue. Bone is a dense tissue. It's going to absorb more X-rays. And when you absorb more X-ray, it's going to show white or light, brightness on the image. That's the summary of CT scan. Any CT scan you see, autograph, okay. Where are the something? I have something on.
Huh?
I'm sorry.
Yes, complete. Not
You check my check it.
Yeah, Mojaki is.
18.
I have display of okay. So the summary of CT scan is that a dense body tissue absorb more X-rays, and when it's projected on the field, it's going to show white or light. Unlike water, unlike nerve in the body. Now, for MRI, MRI tells us the amount of proton energy that the body can absorb. If you see any white areas on MRI, it means there's high signal. And like I said earlier regarding the CT scan, the dense body tissue like bone absorb more proton and it's going to show white. Now, for MRI, there are two images they usually project. Type T1 images, that's a T1 weighted and T2 weighted images. For T1 images will show the tissue, the fat that is going to be bright because it's dense, whereas T2 imaging will show you combination of fat and water. I don't want us to go through this way. Now, earlier I've said that our assessment will be based, I want us to go into assessment of two regions in the body, the lower back and the knee. Now, when the patient comes in for lower back pain, there are a few assessments we do, which is forward bending, anterior forward bending, side flexion and rotation, and so on and so forth. Now, during forward bending, when you have your patient to bend forward, forward bending doesn't occur alone. It occurs along with flexion of the hip. Colleagues, now there's a question I want to ask us. At which stage of forward bending does hip flexion comes in? When your patient is inside, you ask your patient, I want you to bend forward as you want to touch your toes. So forward bending combines forward bending of the lower back, combines flexion of the lumbar region as well as hip flexion. I also want to tell us at which point during the process of forward bending, which one comes first? Flexion of the lumbar region or flexion of the hip? Colleagues?
I think it's the hip that should come first. The hip should come first before the spine. That's my thought.
Excuse me, I can't hear you. That line is breaking.
Can you hear me now? Hello?
Okay, can you please come again?
Yes, I think the hip must come first before because the hip is more mobile than the spine. And that's my thought.
Yeah, true. The hip is more mobile than the lumbar region, but one of these initiates the flexion first before the other ones come in. So I want us to know so that when we are examining our patients, patient might carry out what we usually refer to as compensatory movement. When you ask, okay, let me just, when you ask your patient to do forward flexion, forward bending, the movement starts from the lumbar region to a certain degree. Hip will take over, hip flexion will take over to a certain degree for the final completion of the flexion of the lumbar. Whereas if you ask your patient to do backward extension, it starts in the reverse. That's extension of the hip, followed by the extension of the lumbar, and that's completed. Do I repeat it? And sorry, I'm doing four flexion. Sorry, there's what we call anterior movement there. Let's take note of all this while examining our patient. Your patient is doing hip flexion, four flexion. Hip flexion will come, followed by the lumbar, then followed by anterior pelvic tilt. And when your patient carry out four bending, what happens to posterior annulus fibers? There will be disappearance of lordotic posture. There is compression of anterior part of the disc. Facial joints at the back will separate. They will up glide. Whereas if I ask your patient to do backward extension, reverse is the case. Now, another movement we ask our patient to do is side flexion and rotation. Colleagues, these two movements are called couple motions in a normal human being. Side flexion does not occur alone. Rotation does not occur alone. The two occur together. If you ask your patient to side flex, there's an element of rotation. If you ask your patient to rotate, either to right or left, there's an element of flexion. Now, the funny thing is if you ask your patient to side flex to the left side, there's an element of rotation to the right. And if you ask your patient to rotate to the left, there's an element of side flexion to the opposite side of that rotation. So these two motions, side flexion and rotation, they are called couple motion. But studies have shown that in a pathological case, low back pain, fracture, TB of the lower spine, of the lower back, these two motions occur in the same direction. Side flexion occurs to the left, rotation occurs to the left. So when you're assessing your participant, your patient, take note of all this. Ask your parents to do side flexion. It's a pity that you cannot visually see what is going on during the side flexion or rotation. But studies have been shown to let us know that the two do not occur alone. They are twins. They are husband and wife. So I don't know which one is husband and which one is wife there. So landmarks, iliac crest, posterior superior spine, anterior superior relaxed spine, the greater trochanter, the ischial tuberosity, fibular head. Check the well, we are assessing our patient. Okay. The purpose of lumbopelvic hip clearing is to make sure that we find out where the problem is coming from for our patient. Is it from the lumbar spine? Is it from the SIJ? Or is it from the pain? So pain from any of these sides can mimic low back pain. So for us to achieve, to be sure, we have to carry out some functional tests. We have to carry out lumbar and hip active range of motion, with or without overpressure. We have to carry out segmental mobility, which we are going to do later for the lower back. So anytime we are assessing patients for pain in the lower back, please let's screen lumbar region separate. Let's screen SIJ separate. That's sacroiliac joint. Now, few of the functional tests you can do, you can ask your patient to ambulate, to squat, to stand on a single leg, or to hop, or to do heel bouncing. You can also assess the range of motion and look at the quality of the motion, type of location of the symptom, what's the behavior of the movement to the symptom. Is there any resistance in the movement? Is the patient willing to carry out each of the movements you ask your patient to do? Look at the movement quality. And look at the type of location of the symptom. Does the movement alter the patient's system? Does the movement increase the pain or reduce the pain? Does the movement reproduce the chief complaint of the patient? If the patient carry out the movements, how far does the pain radiate to the lower limb? And we also try to carry out repeated movements to know whether there's any centralization there, whether there's any peripheralization, whether there's any alleviation or abolishment of the pain, whether the pain increases with repeated movement, or whether repeated movement has no effect on the patient's symptoms. We've explained this earlier. These are the tests we should do. Now, for lumbar region, these are the few treatment examinations we have to do. Lumbar extension, lumbar side bending, and rotation combined. In this position, your patient will be in standing position, weight bearing position. Let me look for one of the therapists here. How many of us are here? Please, I want to choose one of us as therapists so that we mention the name. Okay, let me choose Blessing. No, hope you don't mind Blessing. Blessing, I'll be mentioning your name, please. Okay, now in this situation, our therapy is going to be Blessing to carry out the lumbar extension, side bending, and rotation in a combined motion. Patient X will be in standing position, a weight bearing position, and Blessing, who is going to be our therapist, we stand at the opposite side of the patient, opposite side of the side one, assuming the patient is presenting with a localized pain on one side of the body or centralized pain. So you stand beside by the patient, face the one side of the patient, the side you want to examine. Blessing is going to put her hand across the patient's chest, which is what I showed, which is shown on the picture there, across to the left shoulder, and the other hand will be touching the patient's lower back. And the procedure is that Blessing is going to guide the patient into lumbar extension, left side bending, and left rotation with the right hand that is on the patient's shoulder. We want to use this to know the amount of movement that is there in the lower lumbar region. We also want to know whether this combined movement, quadral movement, will reproduce the patient pain. So that's the couple motion for that. Combined motion, quadral motion. And the next one is the lumbar side glide. Our patient will still be in standing position, where the therapist will be standing beside. That's the Blessing. Do I have to demonstrate this? Shall we?
Yes, sir, if you can.
Okay.
Yes, sir. You should demonstrate.
Can you see? Please, can you please come here? Excuse me. Face this longer. Can you see my subject? You see him? Can you see him on your phone?
Yes, sir.
I'm standing on the left side of the patient. This is my left hand on the patient's shoulder across the chest. So I'm going to use my hip to stabilize his own hip. This one is to stabilize the shoulder, while the movement will be here. Stabilize the upper part. This, don't bend backwards, stand straight. What I want to do is to move. I'm going to pull the right posterior iliac spine towards me while I'm stabilizing the hip. So I'm going to move towards me. Just relax, please. Oh, don't bend your leg. Just stand straight. I'm going to pull him towards me. Pull him towards me. If you feel you cannot put your hand across the patient's shoulder, you can put your hand on one on the shoulder joint where you are standing on and stabilize the hip. Then push away the shoulder from you and move the hip towards you. Move the lumbar towards you. Thank you. The next one is a lumbar compression and distraction. Let me just leave the camera. Can you see now?
Yeah, keep demonstrating, sir.
Can you see now? Okay. Just move it. Are you serious? Move to the edge of the chair. No, Shigo. So, ask me to move to the edge of it. What I want to do is to distract the lumbar region and to compress the lumbar region. I'm going to start with the compression of the lumbar region. The patient is going to sit upright, and you stand behind him or her and bless reproduces or give the patient pain or no pain at all.
You are muted, sir.
For distraction, Blessing is going to put her hand under the patient's flexed elbows. This is flex elbow for the right, flex elbow for the left. Now pull your patient up. Don't ask him not to stand up. You should not stand up. So it's going to pull him up and sustain for 20 seconds. And find out whether the patient pain is relieved or is increased. The first one was compression. Then the next, okay, this is distraction. Please, why carry out distraction? Any of the movements, any of the tests want to carry
Where
on.
were you holding? Where were you holding in that distraction?
Can you see my hand? I ask the patient to flex his elbow. And I put my right hand under the patient's right elbow, my left hand under the patient's left elbow. And I pull him up.
Okay.
Using this. Now, I also want to say that as physiotherapists, while we are examining or managing our patients, we have to be aware, we have to take care of our own posture. When you want to carry out distraction compression, make sure you assume the proper ergonomic posture so as not to cause problems for your back. This is the picture anyway. This is for distraction. Now, adverse neural tests. These tests are used to make our nerves angry. Let me use the word angry, to put pressure on the nerve. One of which is SLR. So people are saying lactate test and SLR, they are two different things. But for this presentation, I want to use them as the same thing. For us to do the SLR, you ask your patient to be in supine position, keep the knee straight, and the hip straight. Ask your patient to dorsiflex, and ask your patient to dorsiflex the ankle. Can you please lie on that? Lie on the couch. Let's move it there. Let him down the back. Contact. This far. Have you unplugged it? It's not charging. Okay, can you see it? Can you now see it? Okay, I'm going to use my subject's left lower limb. The patient is in supine position, so I'm going to ask him to dorsiflex the left ankle, ask him to pull his foot up. To dorsiflex this, and I'm going to advise him to lift up the left lower limb while keeping the knee straight. We should not bend the left knee while lifting the left lower limb. So I'm going to ask him to do it gently. So please, Dagaka fan kasama. Kada. So this is okay. This test is positive if the pain comes in less than or equal to 40 degrees of hip flexion. It's positive. Now, there is a question I want to ask my colleagues again. How do you differentiate between positive lancet test and positive test for hamstring tightness? Let's go back. Let's go to answer. This side. Colleagues, how do you differentiate between positive lancet test and positive hamstring tightness test? This is going to bail us out.
Hello, sir.
Yes, sir.
Good afternoon, sir. Well done, sir.
Thank you, sir.
Yeah, okay. What I know is that for if there's hamstring and stretch, the knee will be if you want to, can you hear me, sir?
Yeah, I can hear you.
Okay, if you want to confirm whether there's hamstring tightness, the knee will be slightly flexed. When it is flexed to like angle 90, it will be gradually taken into extension. So if there's tightness, the knee will not be able to come into full extension.
Okay. That's how to differentiate between the two. Thank you very much for that. So
you're welcome, sir.
We can also add on.
Okay.
If you don't mind, Professor.
Please, I don't mind.
Yes, so it is important to note that the hamstring is a dihydroidal muscle. So it is crossing two joints. And therefore, when it is tight, there will be active insufficiency, meaning we cannot be able to go further in range of hip flexion or other extension because it is a muscle that is crossing two areas. So when it is tight, there will be active insufficiency. Thank you, Professor.
Thank you for the contribution. Now, the next thing on advanced neural tension tests, like you guys said, advanced neural tension tests is to make nerve angry. You want to make them angry. You want to provocate them. The next one is called slump test, in which you ask a patient to sit on the couch and spine erect as much as possible. Can't be calling. We are going to ask our patient to put the hand behind him or her, and the therapist, blessing this time around, is going to stand. Can you please do slump test? Slump test, yeah. Sit on the couch. No, hey. This is what my colleagues want to demonstrate. So, excuse me. Can you see me? Can you put the hand behind you? So, I'm going to ask him to keep back straight, flex the head down, while arm extending the hip and the knee, and put a bit of upper pressure. Can you see it? Okay. I will suspend it for a few seconds. We just want to know whether there's any pressure on the nerves or not. The next one is Eli's test. Do we have to go through this and explain? Okay, for Eli's test or Ellie's test, we want to test the integrity of femoral nerve. So we are going to ask our patient to be in prone position without anything under the waist. Can you please lie on your chest? Everybody take it. Is it visible now? Let me just leave the system like that. So our patient is in prone position. So sometimes I don't usually advise my patient to use pillow, but it depends on your discretion. So I'm going to just flex the patient knee, stabilize the posterior splenic spine, put my hand under the patient's left knee, and extend the hip. Don't move it. Ask your patient to relax as much as possible and extend the hip. You should not resist it. It's again you can. So I'm going to just extend the hip, hold it for a few seconds, and find out what the patient feels. This test is positive, which the patient says he feels the pain at the front of the thigh. It means you stretched the femoral nerve. You stretch the femoral nerve. Now, the next one is a spinal instability. You have to go through all this. When we examine the patient, it's better we know the integrity of the supporting structures, the local supporting structures of the spine. Our spine are being supported by some local muscles. In the back, we have the global muscles, we have the local muscles. So when you are assessing, we should focus our attention on determining the integrity, the status of the local muscles like multifidus, lumbar multifidus, the transversus abdominis. So for us to know whether there's any instability in the lower back, we carry out a test that is called prone instability test. Prone instability test. So, okay. So we are going to ask our patient to change the position. Please, can you get down? Let's move the couch there. Okay. Can you see from here? Okay. Then maybe you move it. So I want you to stay like this. Okay. Then later you're going to do something. Again. Now this, our patient has assumed the position we want him to assume. So we've done our digital compression test. We've known where the pain is. We just want to know whether that lower back is unstable. So we ask our patient to lift up the two lower legs and keep the knee straight. Up, Dagasama. Keep the knee straight. So let it go, then let it start again. Oh yeah, lift it up. And the patient said that there is pain, there is a bit of instability of movement in that region. You ask the patient to go to the starting position. Let's go down. Relax, get the kinka. So the next thing we do is to exert pressure on the lower back. That pressure is going to mimic a supportive device to the lower back. So you are going to press down and ask the patient to lift up the two lower limbs. Dagasama, Kafanka. So say, while lifting it up, the patient reports that the pain reduces or the feeling of instability reduces. It means that test is positive. While lifting up, the patient reports that there's reduction in pain or the feeling of instability reduces. It means that test is positive. Put it down. But yeah. So, but it is advisable, colleagues, whether your prone instability test is positive or not, while treating your patients, always put them through stabilization exercises. Whether this test is positive or not, that's one personal advice. Because it has been shown that once there's an episode of low back pain, there's always a weakness of the local muscles that are supporting the lower back. So it's always advisable for us to put our patient through stabilization exercises whenever we are managing them. We've done this. This is another form of prone instability test. These are now. I want us to few of the things we've done so far. They are for lumbar region. So I want us to have a look on how to screen, how to clear the SIG. And we are going to start with one of the provocative tests, which is compression test. We are going to ask our patient to lie supine. Letting that one is back. We stop by one, Abby. I want us to look at the hip. You put your hand on the ASIS laterally. Can you see me? And approximate the hand with pressure. Now this is compression. This is distraction. One hand on the ASIS, the other one on the other ASIS. Then beat a bit of pressure, press down, and find out what the patient feels. Is that the pain increases or no pain? I think there's a confusion between the two. So the next one is Gessling test.
Sorry, sir. Hello, sir.
Yeah.
I have a question, sir.
Okay.
Please, can the compressor test be done in a sideline position? Because
it can be done. It can be done.
Okay.
Well,
okay, sir.
Some people, my views regarding compression distraction differ from what I read in the textbook. I need to be I hope I'm with my colleague here. Let me show you this picture. It's okay. Let's continue. The next one is Gessling test. We put our patient in supine position. In supine position. Yeah. Move to the edge. Let me move to that side. Can you move to the edge? Patient move to the edge of the couch. Come out. Yeah. Drop this leg. You now flex the other one that is on the couch. It's tight. And flex the one of the hips and while extending the other. This is Gessling test. Any pain? No pain. Is the pain increase? No increase. You find out what the patient feels while carrying out the test. The next one is a tight thrust. Place the patient hip and knee. Put your hand on the patient buttocks and exert a downward pressure. Why examine? Your hands should be touching the the SIS at the back, SIG at the back. Your fingers should be touching it. And when you give a downward pressure, you observe the movement that is going on there. Number one. Number two, you also find out what the patient feels, whether there's any pain or not, as you are exerting a downward pressure on the SIG. This is being done on the right SIG. You want to do that of the left, you have to move to the other side. No, just hold on. That first. Okay. Another test for us I want us to do is what they call long sit innominate test. Long sit innominate test. A patient will be in supine position and keep the leg straight as much as possible. Can you please come down a bit? Okay. Lie straight, like a military. And make sure the patient is straight in supine position. And we put our thumbs distal to medial malleolus of the left, the other thumb distal to medial malleolus of the left, of the right. And we ask our patient to sit up. Tashi? Sit up. While patient is sitting up, we observe whether there's any changes in the approximation of our thumbs. If the problem is from SIG, it says that the thumb moves up like this, or move down. Now, I need to explain something. Let's assume the patient pain is on the right side, and there is increase, and your thumbs on that right side move down. It means you feel as if the right lower limb is longer than the left. It means there is anterior torsion, anterior nutation, or anterior movement, anterior shift of the right SIG. While the patient is in sitting position. While in sitting position, at the end of the test, you observe that the painful side, let's use right now, the painful side is shorter. Your thumb move up as if the right lower limb is shorter than the left. It means you have posterior nutation, posterior shift of the right SIG. But there are a few instances in which you have no changes in the limb length. If there's no changes in the limb length, it means that test is negative. Do I explain again?
Yes,
colleagues,
sir.
our SIG can either move posteriorly or anteriorly. If the pain is coming from the SIG. If the patient SIG moves anteriorly, it means there's anterior shift. And there's pain on that side, it means there's anterior shift of the SIG. Then the lower limb on that side will be longer. Okay. Now, if there's posterior shift, The lower limb in which the patient is having pain will be shorter. Let me, please, do you get my explanation?
Yes.
Yes, sir, I
Yes, sir.
got it.
Yes, we got it. We got it.
So, and there are different ways of, okay, I'm not the one talking about management. There are different ways of reducing the anterior, managing the anterior nutation, posterior nutation. Hello?
Hello, sir.
Yeah. I'm with you.
Yes, I want just to appreciate you for all these demonstrations so far. But this nominate test for SIJ, is there any, what you have just done, a lot of people are having some challenges in terms of controversy. Is there any way, because if we put the two manolars and then trying to observe when the patient is coming up to see whether there's going to be, difference or in shifts, either one longer than the other. Is there no way that we can actually, assess it objectively in terms of putting a kind of demarcation to ascertain the positions of the two manula, both the left and the right, using a tape rule, for example?
Yeah,
using a tape
okay.
rule. If we use a tape rule to mark, other with a chalk to demarcate the direction, the line, the position of the two manula, both the left and the right, so that we will be able to ascertain which one actually shifts at the first time. Because if we are using
that line, your line is breaking. Hello. Your line is breaking, please. Will you mind if I respond, please?
Okay, sir. Okay.
Yeah. It's a good thing that whatever we do it objectively. Do you get my point? And I've never used a tape rule to measure to assess SIJ movement in my patient. What I've been doing is putting my thumb distal to malleoli. So it won't be a bad idea. Maybe one can try it. Then another thing is the objective where I know that I read somewhere, which I've forgotten, to send for patient for a motion X-ray. Motion imaging. The patient will carry out some motion and the focus of the imaging will be on the SIJ. They're going to let us know which one is moving, which one is not moving. The one that is moving, at what angle is it moving? Which I can't remember where I read it, but the only subjective way I know is what I've demonstrated. So, are we together?
Yes.
Yes, sir.
Thank you. All right. Now, the next one is to clear the SIJ, what they call Gillette matching test. In this, we are going to ask our patient to stand, face the wall, and we are going to put our hand on the dimples on the patient back. Ask the patient to stand on one leg, flex the hip and the knee on the leg he is not standing on. So if there's any inferior movement of the joint of the dimple where the patient is not standing on, it means there's problem with the SIJ. So I'm going to demonstrate it now. We have to ask him to stand by the wall. You can please ask him if he doesn't mind, just let him stand there. He doesn't mind me touching his dimples. Let me find out from it. He doesn't mind. Doesn't mind. Can you trim it? Or you turn that? Okay. Now, I want you to stand by the wall.
But we can't see you, sir.
Can you? Someone is
Okay, yes.
filming it. Can you see him now?
We can see. We can see you now.
Okay.
No, we can't see you. I can't see you.
We can't see you.
Okay, let's come in.
You
Stand
can
like
see
this.
the object.
Can you see him now?
Yes, we can.
Okay. So I'm going to put my hand on his dimples. My thumb on the right dimples on the back, and the left thumb on the other dimples on the left. So I'm going to ask him to stand on the left leg and bend the knee and the hip of the right leg. So bend it. Ask him to stand on this leg, and please tell him, Hausa, bend as much as possible. Yeah, Dagasama. Bend it as if you want to touch your chest. You should bend this one more. No. Let me show you. Look. This is what I want you to do. Again. And you should keep the knee straight. You keep this knee straight. This is the dimple here, this is the dimple here. Now we have to stand on this leg, then bend this way. So the idea, if there's a problem with the SIG on the right that is being bent, my thumb on the dimple should go down. Any downward movement of my thumb is going to show that there's problem with the right SIG. Do I repeat it? Put it down, put your leg down. Now,
yes,
the patient has assumed the position we
Hello,
want him
sir.
to assume. Yeah.
I think when it flexes his knee and hip, ideally there should be a backward rotation of the pelvis, that's the iliac crest rather, and by default the PSIs, the inferior part should go downward when it flexes. I think it's normal. I think it's normal if the PSIs
It's not in all cases. There is supposed to be movement, but not the movement you see downward. That PSI moves is when you do the backward extension of the back, where we have posterior movement of the pelvic movement of the pelvic region. When you have your patient to do backward extension, there's corresponding movement of the PSIs. But once the patient is standing on one leg, there's not supposed to be any movement there, especially on the part that is not standing on.
Okay, sir.
So if patient complains on the right, and while flexing the hip, the right hip and the right knee, oh yeah, try it again. Now there's no movement here. It means the test is negative. Put it down, put your leg down. Now let's try it again. As he's doing that, try it again. If my thumb is moving down, it means the test is positive. There's problem with the left, this is right, SIG. My thumb is moving down, Dagasama will say, it means that test is positive. So, and it's advisable for us to repeat the same test to the other side. Are we together?
Yes.
Yes, sir.
Okay.
Hello, sir.
Yes, sir. I'm with you.
Sorry. Can you hear me, sir?
I can hear you.
Okay, sir. Based on what you just explained, that when it stands on one leg, the leg that is not bearing weight on, that the PSIS should not move inferiorly. What about if you need to correct? Is that not a concept we use to correct whenever there's LLD and you want to manually correct it? I feel that that's the concept we use. That, for example, if there's anterior pelvic tilt on the right leg, what you do is that in order to correct it, the right leg is lengthening. You tell the patient to flex the right leg. That's
Well
bringing it
done.
towards the chest. And by doing that, you are correcting it. I feel that there's a concept around that. By default, whenever you flexes your hip, the PSI should move inferiorly. But that's just what I feel that I've read somewhere. Probably I can get clarification on it, sir.
Okay. I can only say what I know. You get my point. So knowledge is diverse, is wide. You get my point, and I won't mind getting more literature from you regarding that. You get my point?
All right, sir. You can go ahead. You can go ahead, sir.
Okay. Okay. Now, these are the imaging we spoke about the other time. These are the images for the normal X-ray of the lower back. Though the one that they call normal, there's reduced lumbar lordosis there. So, which is, let me call it apparently normal. The other one is abnormal. You can see the changes there. Marginal osteophytes, loss of normal lumbar lordosis, reduced joint spaces. That's for the X-ray of the lower back. Now, this is for MRI, or for T1 weighted that shows the fat. This is for T weighted that shows the fat and water. This is the CT scan for normal lumbar. And this for the abnormal one. So I also don't have time to go through the hip. Should we start hip assessment? No?
Break.
Or go on break?
Let's go on break.
Break, sir.
Okay, so we should go on break.
How many minutes
How
break, sir?
How many minutes break? Let's agree.
Let's
It is not 40 minutes.
Okay, one.
Let's reconvene at 2. Let's reconvene at 2
Yeah,
p.m.
one of my bosses is telling me that if you go on break, once you come back, another colleague of ours will start the presentation. And I have about how many, like 20 to 30 slides more.
Definitely, we will probably not be able to cover that at 2 p.m.
Continue, sir. Continue, sir. You should continue.
Okay.
Let's continue, sir. Let's continue.
Okay, I want to go back to the last slide here. Okay. Physical examination for the hip. We check the gait like you have to go through all these. Okay. These are the things we explained earlier: selective tissue tension test, active movement, passive movement, internal and external. Okay, let me just go to all this assessment for the hip. the first one is the distraction of the hip joint. And we are going to put our patient in supine position. Blessing is going to stand at the edge end, at the lower end of the couch. And she's going to ask someone to hold the patient waist so that there won't be any movement. Can you help me? I want you to hold there. Can hold it like this. So, this is distraction. I'm tired. Okay. Okay. I've asked someone to stabilize the patient from movement. So the distraction is being carried out. I distract the patient hip and find out what the patient feels. This is one way of distracting the hip joint. But distraction carried out like this doesn't fall only on the hip. It falls also on the knee. So if I want to localize my distraction, ask the patient to relax. I'm going to grasp the patient thigh, proximal to the knee, then distract.
Can't see the video, sir.
They can't see me.
We can't see the video.
Yes, sir. Please, you are back to me, sir.
Okay. This is the first one I did.
Yes.
But I said, carrying out distraction like this doesn't make the effect to fall on the hip alone. Distractive effect falls on the hip and the knee, especially on the knee and the hip. But I want this thing to fall only on the hip. So I'm going to put my patient lower limb on my shoulder, grasp the patient thigh proximal to the knee, and pull, and find out what the patient feels. This is inferior glide for the hip. We continue. Ready? Okay. Okay. Oh, show my back. Done. Let me not there. What of now?
This green and this one should be.
So, graphs, you pull posteriorly and laterally. Inferiorly, sorry, you pull inferiorly, then move it laterally. That is gliding. Pull it, then laterally. Please relax. You pull it inferiorly, then exert lateral pressure.
You are backing us, so we're not seeing the front. You are
Someone, are you not showing from your video?
You are backing. You are backing up.
Sure.
Is there any way to?
What of now? What of now?
Okay, yeah, that's better.
This is the patient move the lower limb. So just relax. So I said you pull inferiorly and push laterally. Push and pull inferiorly and laterally. Position. This posterior glide. Position.
Change it to this one.
Okay, are they getting it from your phone?
Yes, sir.
Are you seeing me there?
But sir, the test you did now, which one is positive? How do you know which one is positive or negative?
If it is positive, why pulling and distract laterally? You pull inferiorly, then push laterally. The patient might tell you there's pain or there's no pain. You just want to know which of this movement is going to produce pain, patient pain.
Okay.
Yeah. What's the next one? Posterior glide. The ideal thing for me is to ask someone to stabilize the patient's hip for me so that the traction will fall. And that. The next one is posterior glide. Still, you pull inferiorly and press down posteriorly. Pull, then lean forward and press down. Pull, lean forward and press down. Or you pull and press down and find out which of these movements give the patient pain. This is posterior glide. Pull inferiorly, then Exert downward pressure towards the patient, directly to the patient buttocks. Pull, then downward pressure.
Hello, sir.
Yes, sir.
Yes, sir. Please, I want to ask, in the case whereby the patient is whether the patient is a ectomorph and the therapist is an ectomorph, that's a skinny, and you can't really grab the patient's the extremity you want to perform the inferior glide and the posterior glide. How do you go about it? Because at times these are some realities that we face. It's as if the destructive force you are applying is not enough to really cause what you need. So is there an alternative way to go around it?
Let me answer that. On few occasions when I experience something like that, I invite a colleague to do it for me, who is more masculine, who is more bigger than me.
Thank you, sir.
Or alternative, because the environment where I work, if I want to do something like that for a female patient, I invite a female colleague to do it for me. I only have to describe what I want and what to expect, if it's positive or negative. So this is anterior glide. For anterior glide, our patient is going to be in supine position. You need to repeat all this. This functional demonstration test. Can you go on break? Please, colleague, can you go on break? I'm tired. The remaining ones are not difficult.
Yes, sir, we can do that.
Please, I'm tired too. And you are going to get the slide from the organizer. Kato, can I get better? So let's go on break and come back in the next 40 minutes. How do I pause? How many slides are? Just 2 or 3 more slides.
Oh, every week. How do you
Have we not started? Good afternoon, all.
Good afternoon, colleagues.
Yeah, good afternoon, sir.
Good afternoon, Prof.
Welcome, Prof.
I don't know what is happening. I don't know. What if CPD make saying MRTB not to shit here?
Hello. Hello, Prof. We are still waiting.
Yeah.
Good afternoon, colleagues. Can we start, please?
Afternoon, sir.
Yeah, I thought we have waited enough. I think we can just go ahead.
Okay, sir.
All right. So please permit me to share my slide. Is the slide visible?
Yes, sir.
Yes, sir.
Yes, sir.
Dr. Billiard. I mean, Professor Billiard.
I have been trying to reach out to organizer so that he can.
Just for supplies.
We have done all the registration as well as the preliminaries at the early morning in the first part of the presentation. So there might be no need for us to go back to that aspect. So I want to ask us that we could just go straight into the presentation for now. Is that fine? Can we just go ahead?
Yes, sir. Yes, sir.
Yes, sir. All right. So please, I want us to just understand that this aspect will strictly pay attention into the principles of treatment and rehabilitation of musculoskeletal disorders. I believe the earlier session has taught us how we're going to understand them, and then how do we assess, and then we make diagnosis of the specifics of these MSKs or MSDs. So depending on whichever we're trying to look at, we must understand that your successful treatment depends on how successful you're able to get the correct diagnosis following your evaluation and examination. And I believe that has been properly covered earlier. So in this aspect, we're just going to talk briefly about understanding the MSK disorders. Of course, we have looked at the assessment and diagnosis. Then we'll go into the principles of the treatment. When we talk about the principle, we're looking at the those paradigms, those aspects that you just have to do for you to be able to get a successful outcome or a good prognosis of the condition you're looking at. Of course, we also want to look at our rehabilitation protocols, and then perhaps we take a case study, and if time permits us, we're going to do some practical demonstrations. Of course, we're going to open the question and answer session, and then we're going to conclude from there. Well, the practical demonstration will have been where we had a physical session so that we can ask questions, we can use ourselves as the demonstration. But nevertheless, we want to see how best we can do that. Now, as a way of introduction, I said musculoskeletal disorders, they involve injuries or conditions that affect our musculoskeletal system. And if this is the case, it means almost every individual is likely going to present to the physiotherapist with one MSK or the other. Because you're talking about injuries that has to do either with the muscle, the ligament, the joint, or you're talking about the bone itself, and all the skeletal tissue of the body. I say example of an MSD is arthritis, where there's inflammation of joints, which causes pain and stiffness. Or if there's ligament or whatever, you could have tendinitis, and due to these, you could have serious problems with that part of the body. Of course, you can have MSD as a result of muscle strain, or we talk about overstretching or tearing of a muscle. The same way you look at ligamentous sprains. Okay, I think it's fine now. I hope you can hear me now. Are we still having the glitches?
Yes, I can hear you, sir.
Please, yeah, kindly mute yourself so that we can be on the same page. I said musculoskeletal disorders can occur as a result of fractures, or back pain, neck pain, and so on and so forth. I said when you have any of this MSD, the impact on your life. One of the impact of MSD is when it impacts your activities for daily living. That is, its impact on our ADL. In this time, it could lead to limitation in your mobility. A musculoskeletal disorder could lead to reduction in range of motion in the affected joint or muscles, which makes it difficult to perform your daily task. Of course, you can have...
Professor, excuse me.
Yes, please.
Seems we have lost your presentation.
Oh, sorry, you're not following?
Yes, we are see the screen.
Hello, only the video is lost. Just the screen. We can't see the screen, but we can hear you.
Okay, so let me see. Okay, maybe there's a possibility it didn't share again. Let me reshare my slide. Are we up to it now? Can we see that?
Very okay now. Very okay.
Yeah. Yes. I was trying to talk about the impact of musculoskeletal disorder on our activities for daily living. Because when there is a musculoskeletal disorder, it means what happens to the individual. And I mentioned that it could affect your activity for daily living. It will impact on your quality of life. It can even impact on your, on your everyday life. So what I'm trying to bring up here is the impact of musculoskeletal disorder on our activities for daily living. And I said one of the impact it has, it causes reduction in mobility. Because when you have a musculoskeletal disorder, it could reduce the motion, the range of motion in the affected joint. So either the joint or the muscle will be affected, and then the individual will not be able to perform their everyday task. I said it can also create difficulty or challenges with activities of everyday like walking, bending, lifting. So when these problems are there, it means it has to call for attention that we need to solve it. We must also understand that musculoskeletal disorders could also lead to dependence. You know, it creates, you need assistance in everything you need to do. So, and when there is need for too much support, for care, you know, it becomes a burden, not to the individual, and of course, even to the caregiver. So there's likely going to be problem with your dressing, you know, grooming, even in terms of hygiene. You're going to have problems with that when an MSD is not properly taken care of. I talked about it's also going to cause limitation in your work. It said when you don't have good strength, or you don't have an intact musculoskeletal system, it affects your ability to perform your job-related tasks. In essence, it reduces your productivity and increases absenteeism from work. Of course, when you also have issues with musculoskeletal disorders, I said it reduces your participation in your hobbies. That is, your recreational activity, things you like doing, becomes a problem because you'll not be able to fit into the environment as much as possible. Another way musculoskeletal disorders can affect us, its impact on our quality of life. Because when you have MSD, it leads to chronic pain. This chronic pain can be a persistent pain that could affect your sleep quality, which will lead to fatigue, and of course, it reduces your overall well-being. When you don't sleep well, and then you have pain consistently and persistently, it gives you this inability to sleep properly, or you enjoy your sleep, which also creates fatigue whenever you wake up. Another problem with musculoskeletal disorders are that they decrease our physical fitness. You know, when you have issues that affect your muscles, your bones, your joints, it eventually may lead to inability to exercise properly. Of course, when you don't exercise properly, you're going to have reduction in your cardiovascular health. And of course, as well as your muscle strength and all that, everything goes down. And then this may even lead to what we call the social isolation. You can't go out to jog, you can't go out to walk with your friends. So it leads to social isolation. And social isolation will just lead you to what? Avoiding activities that you could have been enjoying even before now. So it makes sure that we must take care of our musculoskeletal health. Because if we don't do that, it's going to lead to so many problems. In fact, it can even lead to financial burden because your medical expenses will increase. There will be increased visitation to hospitals, increased education of medications, as well as need to see specialists. And of course, it causes you to spend more money, you know? And of course, the ability that you lost your time to go to work and make more money will lead you to spend more. And of course, you're able to earn, you'll be earning less. So all these are burden. Another issue with musculoskeletal disorders is that they lead to loss of independence. We mentioned that earlier. They'll be needing a helper, a caregiver that was, you know, even if it's a family member or wherever, it's constantly going to be around for your activity of daily living to be done. Now, MSD also impacts on our mental health because it leads to increased stress. Just like what we talked about, the chronic pain, physical limitation, all these will increase your stress level. Anxiety and depression will set in, fatigue will come into it, and that feeling of helplessness and frustration will all reduce your functional ability and increases your pain perception. Another problem with consistent MSDs is that they lead to self-esteem because there's this negative, you know, self-image that you develop. You lose confidence in yourself, and therefore it impacts in your physical health. So all these are mental issues for secondary to musculoskeletal disorders. Another issue we need to understand about MSD, it could lead to emotional distress. Because when you're not able to cope with the situation affecting your nerves, you know, you can imagine a patient with back pain. and that pain is leading to paresthesia, numbness, and all that, you know, the issue of emotional distress begin to affect the individual's life and its impact in his life goals. So all these are realities. Of course, we mentioned about reduced quality of sleep, and we talk about how pain and discomfort may interfere with your sleep pattern, leading to mood swings, mood disturbances, and cognitive impairment. Ladies and gentlemen, generally these are domains that we have to be looking at when we're looking at issues that surround musculoskeletal disorders. Now, I'm just going to quickly rush us to the treatment principles. Because when we say principle, it is those are pathways, those domains, those issues that must be looked into in trying to resolve any type of musculoskeletal disorders. We have defined it as a health condition that affect either the muscle, the ligament, the joint, the bone. You know, it has different paradigms. So therefore, we're not looking at one entity, but whatever it is under the umbrella of MSD, the treatment principle must follow this pathway. Number one, it's about pain management. There's no individual that will come in with all this issue of musculoskeletal disorders that wouldn't be presenting with pain. So therefore, the moment you have evaluated your patient, you assess them, and you realize that one of the things they have is pain. So how do we manage the pain? I'm sorry, we're just having all these glitches. The internet will just go off on its own when it likes. So let me share my slide again. Okay, I'm sorry, we're back. I hope we can see it again. Now, I was trying to mention that the moment you've been able to the primary domain, you must ensure your assessment is the pain. So we must understand how do we do our pain management. So one of the ways we handle the pain is to look at what type of pain are we dealing with. Is it an acute pain? Is it a subacute pain? Or is it a chronic pain? Apart from that, you have to look at what do you have as modalities to take away the pain. Now, pain secondary to inflammation, you know, pain that is of acute stage will respond better to any issue of cryotherapy, that is with the use of eyes, you know, lasers, and then either pulse, ultrasound. So all these are likely going to manage your acute pain properly. But for a subacute and chronic pain, your heating modalities will be of better usage in terms of enhancing the blood flow, increasing, you know, clearance of the pain substance, you know, and prostaglandins along that line. So you must know how to balance between the use of the cold and your heat modalities. Of course, at some point, you must also understand how to use medication. That it means there must be a good collaboration between the physiotherapists as well as our other healthcare providers. So all these are supposed to help us in how to handle the issue of pain management. Number two, I hope we can see the slides. Is it visible?
Sure.
Yes, sir, it is visible, sir. Go ahead, sir.
So this slide is the same with what I said. I just tried to put all the words so that you can see them when you collect it. Now, another domain we need to look into when you come about evaluating or assessing an individual with musculoskeletal problem is the domain of mobility. We have mentioned one of the major problems MSD will cause is to limit your activity for daily living. In terms of activity limitation, which is with mobility, it will have to go through, the range of motions of each joint. So therefore, the aim at this point is how do we restore mobility? And one of the things we use for mobility restoration is stretching exercises. You have to stretch to improve flexibility and the ROM. Of course, you should know that the stretches are expected when the individual's problem has been there for a couple of weeks, months, and of course, it's going into the chronic stage because disuse atrophy will reduce the range of motion to make all the tissues as tight as possible. So therefore, we must understand as a principle, any type of musculoskeletal disorder you're looking at, you must restore mobility. And one of the modalities you have to restore mobility is use of stretches. Of course, in these stretches, you could have what we call the static stretching or dynamic stretching, or what we call the PNF. I'm sorry, I got a bit distracted. Yes. So apart from the stretches, I said we could stretch in terms of either static stretching, dynamic stretching. I think I have that in somewhere. Yes, this is the stretching. It could be a static stretching where you have to hold the stretch for a period of time to improve flexibility. Static stretching could be in terms of your SQE. For example, talking about the static quadricep exercises, like following a patient with either patella repair, patella dysfunction, or when you have somebody fractured the femur, is being under an ORIF device. And of course, one of those exercises you could do is the static quadricep exercise. Of course, we could do the dynamic stretching. This involves an active movement that stretches the muscle to their full range. Even when you're doing the activity, then you stretch at the same time. And of course, you could use the proprioceptive neural facilitation, which involves both stretching and contracting the muscle at the same time. So all these are different stretching modalities one could use. Of course, we also have manual therapy that you will use to restore range of motion or mobility. And our manual therapy could either be joint mobilization or joint manipulation. So it depends on whatever type of joint you're looking at. And of course, you know that there are a lot of grade of movement. It should be gentle. It should be, gradual so that you don't provoke more pain. Of course, there are times that you have to push through into the pain to break into a new range of motion. For example, when you're dealing with stiffness following, a fixation, somebody had a fracture and then the limb was fixed for a period of time, it's likely going to lead to a shortening of those muscle tendons. And of course, shortening will lead to reduced range of motion, so there's need for stretch and then increase ROM. Now, the joint mobilization, it depends on the type of end field you have. That will depend on the amount of force you use. So we all know these. Among the different manual therapy is your soft tissue manipulation or massage. You have a lot of different massage techniques. All of them are meant to enhance blood circulation in that joint, and of course reduce the muscle tension or spasms. So you should know at what time and what technique or what type of massage you should use. So all these are modalities for you to improve your range of motion. Now, apart from increasing the range of motion or mobility, another principle we need to put at the back of our mind is strengthening exercises. It is most of the musculoskeletal disorders are going to lead to what? Reduced muscle power. So therefore, we must put at the back of our mind that we need to do what? Strengthen the individual. Now, strengthening has different patterns and pathways. For instance, you want to use a resistance training, you have a different type of resistance equipment or tools you could use. Apart from the free body training, you could use gravity, you could use free weight. The free weight could be either a dumbbell, a barbell. So it depends on where you're targeting in the muscle for strengthening. Then you know what type of muscle, or type of tool of resistance you need, and the amount of resistance that will be used to build the muscle. I don't want us to go into all the nitty-gritty because I know we're discussing, everybody in the platform are physiotherapists. So you know what it means to identify your 1 RM, from your 1 RM to 10 RM, and then you know how to build your muscle from muscle power 0 to muscle power 5. So all this, I believe, was mentioned in our earlier presentation today. So apart from using the free weight, you could use also resistant band, or called the Terra band. These are versatile and portable bands which can be used. You know, you can modify them for every type of exercises. Of course, you have the blue, the green, the black, the red. So it depends on the resistance you're looking for that the color will represent. So there are a lot of different resistant band that could be used for strengthening. Of course, we could also use our body weight, like the push-up, the squats, the lunges. All these, they use your body to strengthen up. We all know what it means to do push-up, the squats, to do planking and all that. All these are strengthening exercises for the individual. I believe at this juncture, there's nothing, do we need to show anything? I don't think we have to do any issue that we have not seen here as physiotherapists, because these are rudiments, right?
Yes, sir.
Can I continue?
Please, can you make it in slideshow so that some are not seeing it? The writing is small.
Is it good like this? Can we see it this way?
Yes, sir. Better.
Okay. Yes. So I said, apart from the resistance training, we could also do core stabilization exercises. The core muscles, these are the muscles of the back that support the stability and strength of the back. Of course, the core muscles doesn't mean only the back, it also encompasses the abdominal muscles as well as the side muscles, which is the quadratus lumborum. We also have issues, the deep little muscles that help us for stabilization in terms of the multifidus muscle. All these muscles of the back come together to be called the core stabilization muscles. They help to support the spine and improve our posture. A lot of different types of exercises can be done for you to be able to pick up your core muscles. Example is the plank exercises, the bridges. You can use the McGill exercises. You can use a lot of different exercises you can do to enhance the stability and strength of the back. So we talked about pain management. We've mentioned the use of stretching to enhance our mobility. We want to restore mobility. And of course, we want to restore the strength of the part that has been affected by the MSG. Another aspect we should look at is functional rehabilitation. When we are treating an individual with any musculoskeletal disorder, we have to also look at how do we restore back his function. Now, in trying to do functional rehabilitation, most of your activities should be task-specific exercises. For instance, the activities for daily living that include lifting, bending, wearing of your shirt, buttoning the shirt, and all that, So whatever exercises you're trying to prescribe to that individual should be an exercise that will replicate his everyday life. That you know he needs to comb his hair, so the patient has maybe a shoulder problem, then you know that he needs the comb, he needs the shoulder to be able to comb the hair. So whatever you have claimed you have done with this shoulder, you have treated the pain. If the patient cannot return back to combing his hair, wearing his, lacing his shoes, and all, it means there's still a big problem. And therefore, we must introduce functional rehabilitation as a principle of managing what we call the MSD. Of course, if it's a sport individual, so most of the activity you want the individual to do should be sport-specific movement. For instance, if somebody is a lawn tennis individual, so most of the exercises should mimic that movement the individual is likely to do in the sport. Just imagine a basketballer who doesn't know how to dump the ball due to a problem. So if whatever you're treating, you should be able to restore the dunking of the ball, as well as football or whatever type of sport. If it's a cyclist, you should be able to restore back those issues that has to do with a reducing range of motion in the knee, or like individual presenting with a patellofemoral syndrome, you must have to restore how they should be able to cycle. Of course, we should put in exercises that will enhance our body awareness and prevent fall. Ladies and gentlemen, may I ask you at this juncture, what exercise will enhance your body awareness and prevent fall? Colleagues, which exercise are we talking about?
Rhythmic stabilization, rhythmic stabilization.
Rhythmic stabilization is put under what type of exercise?
I don't know under what type.
Probably, Professor.
Yes. Yes,
Hello?
please, colleague.
It's part
Just
of
feel free.
PNF.
There is no wrong or correct answer. I just want to understand, know how we interact with these terminologies. Yes.
Yeah, I think they will be called proprioceptive exercises.
Proprioceptive exercises, yes. So what else? Under which category of exercise are we going to place exercises that enhances your body awareness?
Balance training.
Balance. Thank you, my colleague, my sister. This is very wonderful. It's a simple thing I wanted us to talk about. We talk about balance and coordination. It gives you, it creates your body awareness, and of course, it helps to prevent falls. So these must go into our package of functional rehabilitation. I was mentioning that we could use different balancing system, like the balance board, the single leg stand, you know what we do about the rumble chest and others. So these are all exercises that will challenge the stability of the individual. Very, very vital. Now, in the whole package, in the principle of our MSD, we don't have to, we cannot just give out these activities without bringing in the individual to take care of themselves by themselves. Because it is when they're in charge of their body that whatever intervention you are giving will be able to maintain the situation. Now, I talked about education and self-management. This is germane in any kind of MSD treatment you're giving. So I brought up this pattern so that we have to register it at the back of our minds. Whatever evaluation, examination, or assessment of an MSD you can do, you have to put this principle in place. You want to assess and identify issue relating to pain. Then you talk about how do you manage that pain. Number two, you want to talk about issue that causes reduction in functionality or mobility. That's talking about the range of motion. So we're going to look at everything that has to do with restoration of ROM. So in this case, we're going to look about stretches. And of course, we're going to talk about strengthening, because we want to see what gives the individual the strength to do what they want to do. And I've talked about that apart from stretching and strengthening, there is what you call the functional rehabilitation. Whatever rehabilitation you're giving, It must mimic the daily life. It is return to activity that shows that there's a progress. There is the treatment you are giving is worthwhile. So please, these principles will put them hand in hand. So here I'm bringing up one aspect that we must not miss it in any of our MSD treatment. It's about education of the individual, you know, that is having the MSD problem about that issue. Now I have an individual, a young man who went in for a total hip replacement of his left limb. Now, 3 months post-op, the patient presented back to his orthopedic surgeon talking about he has this sensation, numbness, paresthesia, as well as pain that he says that goes, you know, all over his the affected limb where he has the THR. Now the doctor reviewed the patient and said, well, I think he has back pain. He should see the physiotherapist, and that patient was referred to me. Now the patient came in, the first thing we needed to do was to understand his concern. And he said he has this pain that is of a burning character. The pain does not have a particular pattern. It is scattered all over the front and back of his lower limb and all that. But upon evaluation, there was no any symptom in the lower back. The DCT, whatever type of pressure on the back, elicit no pain, no movement, either back extension, back flexion, side flexion that gives the pain. Now, one thing I only realized is that there was a limb length discrepancy, which made the patient to limp. Now, that limp pain is likely going to do what? To give a slipping of his disc. Now, but because there is no any symptom in the back, the patient refused to believe that he has a back pain with radiculopathy. Don't forget that radicular pain is not the same as radiculopathy. So we should be able to clear that. Now, for this patient, it took the surgeon a lot of time that they had to go and do an MRI, which now shows he has a multi-level disc compression, you know, before he now agrees that yes, okay, he has a problem in the back. Now, it was only when we begin to give him this neuromodulation, that is the education about the pain in the back, that those shooting symptoms you are having doesn't mean anything is scattering in your back. It just means there are positions that when you take, it gives the back more problem. So we had to educate him about the pain itself, the perception of the pain, how that your thoughts, your interpretation of your pain affect your intensity and perception of that pain. So it means a lot of education must be put in together. And you wouldn't believe by the time the patient came for 1-2 sessions, he said his pain, the thing is going. So it's all about the understanding. It's not as if we have not treated him before all this. It is because we had to now sit down and educate this patient about his pain that he begins to understand he needs to buy it that way. If even he feels it, he knows it's there, but it should not be worrisome or bothersome the way he began to interpret it before now. Because what he will tell you that he has this catastrophizing pain. So it is the interpretation that gave him all that. So please, colleagues, we shouldn't forget about education as well as self-management. So ergonomics is one of the things we educate our patient with. Now we identify in that patient that he had a poor posture in his car. It is where he sits in his car that he slouched the car so that he doesn't have too much pressure on where there is an implant. So that's why the patient was not having issues with the back. So we had to go into the car and correct the ergonomics of the car. And then we make sure that he doesn't sit too much in the car because he said he has a semi-office in his car. The patient, most of his job is online. So he's always online. He could be in the car, just put on the AC and he will sit there for a long time because he said he enjoys that position. And it's that position that was giving the back pain. So when we took care of all that ergonomic posture, we're able to put the patient in his proper situation, and of course the pain diminish. Of course, ergonomics will help you to teach the patient the correct way to sit, to stand, and how to move, so as you avoid straining any tissue of your body. Of course, we must also understand what are the techniques that are safe for lifting, carrying, or performing different activities. All this must be known and taught to the patient. You know, with patient with low back pain, we try to avoid lifting of heavy load. Any load that will put too much pressure on the spine must be avoided. So all these are things we have to tell ourselves. Now, we must teach the patient how to take care of themselves by themselves at home. So we create personalized exercise routines that the patient can do at home. These days, what I do for my patients is when they come in and you try to teach them any kind of exercises, you use their own phone to make a video where they can go back home, look into the video, remind themselves how they did, what they did, and they should be practicing at home. And of course, we must have a book where we ensure that our patient understand and the importance of doing these exercises always. And then we have a logbook where we can track their progress. When they see their progress, it serves as a motivation for them to continue. So this is a very, very important aspect we should put into our interaction. Ladies and gentlemen, I want to give us a chance to speak. If you think you have 1, 2, 3 I've been missing or I'm rushing before we go into our rehabilitation protocols. Is there anything we want to talk about so that we pause a bit? And I hope I'm not rushing, I'm not too fast.
No, sir, you are not too fast.
No, sir, you are doing well, sir.
You are not too fast.
All right, you know, it's evening hours. Can we just continue? Then we finish up and before we start our question and answer session, should we just move ahead? Should we move ahead?
Let's move ahead, sir.
Yes, please. Thank you. So at this point, I want us to look at managing our patient or individuals with what we call the musculoskeletal disorders in general. You will notice that we're not choosing or picking any particular condition for now. We're trying to look at it in general. So I said, when you have a patient that presents with a musculoskeletal disorder, and then you've been able to follow his treatment protocol, there are issues that has to come up in terms of rehabilitation. So this rehabilitation has protocol. It has a pattern in which you follow to get the main thing that you want to achieve from this patient. After your proper examination and evaluation, you'll be able to demonstrate that this patient is in which phase of his rehabilitation. So rehabilitation, as we all know, it has the acute phase, you have the subacute phase, and of course you have the chronic phase. One of the phases that we really don't pay attention among most physiotherapists is return to work or return to play, especially for the sports guys. Because if somebody is a professional footballer, he presented to you with an ACL damage for rehabilitation, that patient can never be said to have had a good rehabilitation and until and unless he can return back to that spot, because that is where his job is. And that's why they are different from every other type of individuals. So for a banker, the moment he can just tie his tie and go to the office, he doesn't require anything anymore. But for a sportsman, he needs to return back to his sport for him to know that he's properly taken care of. So at the acute phase, we must understand that the focus at this phase is about pain management, reducing inflammation, and protecting the injured area. So when the patient tells you that the injury was just 24 hours ago, 48 hours ago, or 3 days ago. So all these are part of your acute phase. And what we need to do is at this phase is what are those pain management modality we'll put in place. We've talked about the cryotherapy, we talked about the use of TENS, we talked about the use of ultrasound, laser. So it all depends on what you see. But the main thing is you want to ensure that you are managing that pain properly. And I mentioned earlier that your pain management can also be in collaboration with other healthcare colleagues, talking about a medical doctor, the orthopedic surgeon, a rheumatologist, or whoever is in charge or is managing the patient with you. So that sometimes your patient might need a more potent painkillers before you can commence some other activities you want to do. Of course, in terms of protecting the injured area, we're talking about maybe you avoid walking on the limb, you avoid, you could put a brace, you can bandage the limb. So a lot of things you can use to protect the injured area. Of course, in acute phase, we can start our gentle mobilization, which is in a pain-free mode, of course, to ensure that we are trying to prevent the loss of range of motion at that point, or you're trying to restore the joint in a gradual and pain-free motion. Usually at the acute phase, most exercises should be isometric. That is, we should be contracting the muscle without changing the length of the muscle. And this is at the phase where we teach the patient how to do what we call the active rest. While you are resting, but you're doing the SQE, for instance. So all these are rehabilitation protocol we need to follow at the acute phase. Our acute phase are usually between the first 1 hour to 72 hours. Some colleagues will tell you it to the first 7 days. So irrespective of that, we don't want it to be more than 7 days when you will still be using your acute issues. Now, something I want to call our attention about is with the use of cryotherapy. The cryotherapy, most of us have learned, perhaps maybe we did not pay too much attention. We'll see that colleague will just put cryotherapy for a swollen area or for an inflamed aspect for 15 to 20 minutes and tell you, okay, you do the same thing at night or you do the same thing tomorrow. Ladies and gentlemen, it's not going to help. What you need to do is cryotherapy for every 2 hours after the initial problem. For the first 24 hours, except the patient is asleep, you want him to put the ice after every 2 hours. You can imagine how much of inflammation that will reduce before the first 24 hours. So please, let's stop doing 15 minutes until after 12 hours or until after 24 hours. It doesn't really help the patient that much, especially for those who are in sport physiotherapy. Please, you should pay attention when you want to do your cryotherapy. It should be after the acute stage, the 0 hour, the next 2 hours, and it goes on like that until you're able to take away the inflammation completely. Okay? The subacute phase. The focus of the subacute phase is the gradual introduction of active range of motion exercises. Because this is when you want to begin to make sure that the individual is now moving that part of the body with the change of length in the muscle action. I told us that at the acute phase, the exercises should be what? Should be isometric. And that's why our medical colleagues who don't understand what we do, no, they will tell you, no exercise for now, no exercise. No, that is wrong. We're going to do exercises, but they're going to be isometric exercises. It can be either ankle pumping, it could be either using SQEs and like that. So isometric exercises, acute phase, subacute phase, the gradual introduction of range of motion exercise. And we pay attention to strength training, which is going to be either with free weight, there is no weight, we use only gravity, and then we try to use endurance exercises where we ask the patient to lift the limb and hold, So all this you are introducing strengthening, but in a gradual manner. And of course, as you do this, You also continue your pain management, because at that point, it's no longer the acute pain type of pain that will work. You need more of a heating modality where you begin to enhance the blood flow of that aspect of the body. So the subacute phase is about increasing blood flow. We also have the chronic phase where our focus here should be progressive loading. At this point, that's where you want to continue with your more intense strengthening exercises, where you can start using the calculation from your 10 RM, lifting 1 kg, 2 kg, or like that. 3 repetitions, 10, 10, 3 sets, and all that. So we all know all this exercise pattern. So at this chronic stage is how do we pay attention to enhance the strength of that part of the body. And of course, this is at the region where we begin to talk about functional training. Of course, we talk about conditioning and then advanced strengthening. So functional training is what we mentioned that include mimicking your normal daily activity in the exercise. For instance, we want to reach out, somebody has a shoulder problem and that patient is a woman. Can you tell me what are the basic exercises you want to give that individual for functional rehabilitation? Any person? A woman, say 30 years, a 30-year female with shoulder problem. She has a shoulder pain. And now you're at the chronic phase where you want to bring functional training. What would you want to teach the woman? Yes, colleague.
Yes, can we?
Yeah.
Yes,
Okay.
I can hear a female. Can the female
Yes.
please? Sorry, excuse me. I want the guys to think what they will do. The females, they can easily
Okay,
know
sir.
what they want to do.
No
So,
problem, Prof. No
yes,
problem.
let me take some my guys. Yes,
I
go ahead.
want to say, can pendulum exercise work at that stage?
Dr. Sarafa Amusad, what do you mimic in her daily activity with a pendulum exercise? What are you mimicking?
Yeah, if you want to tailor it to daily activity, we can use other things. I'm just saying generally that pendulum exercise can help improve the range of motion.
Yes.
Hello,
Sorry,
sir.
it's not about
Hello,
range of
sir.
motion. I want us to understand. It's about functional training. And I've mentioned earlier that
Okay.
your functional training are those training you give that mimic her activity for daily living. And I said now
Yes,
we're
sir.
looking at a woman, a 30-year-old woman. What do you think is one of the things that she would need to do for her daily activity? Any person?
Yes, sir.
Yes, who is that? You can unmute yourself and speak.
Yeah, we can. Hello, sir. We can tell her to be tying as a form of exercises.
Okay, that's one. But
Yes, in so doing, yeah.
Okay, that's one. Somebody was trying to speak. Is that Mr. Anthony Kisilu? Are you there?
Okay, Professor.
Yes, please.
I mean, in tandem with your presentation, I think I would tailor movements that mimic the unzipping of our.
I lost your connectivity
Because that
at
requires
that
a bit
point.
of some
I didn't get your
internal
point very
rotation.
well. Please, do you repeat it?
Okay, I'm saying.
Yes.
Hello, hope you can hear me.
I can hear you now. Go ahead.
Okay, for the 30-year-old female, I think I would tailor activities that mimic the unzipping of our bra, because it's something should be doing
Exactly.
almost
Please, a
daily.
round of applause for Mr. Anthony. That's exactly what we're talking about. That is
Thank
the
you.
activity for external rotation of the shoulder. A woman always want to wear her bra, and then she needs to unbutton the bra, to unzip it. And therefore, this activity, if whatever strength you have restored in the shoulder, but she cannot go to the external rotation to get to the middle of her back and then unzip that, it means she's still not restored into her function. So please, those kind of training are things we're trying to talk about. I really appreciate you. Thank you so much. So we continue. We're going to interact with ourselves as we move. Now, we're going to the phase where we talk about functional return to activity. So return to activity is what we meant when we look at the sport guys, we say return to sport. Now, no matter how good your rehabilitation is, but that individual can still no longer do the activity they were doing, then that rehab process is still limited. There's something still lacking. It means we need to do more. It means we need to restore more functionality into that individual. So I said a return to activity, the focus should be gradual reintroduction to normal activities. So instead of me to say, I'm trying to do a balanced exercises or dexterity exercises to the fingers or to the digits, I'm going to ask the individual, can you lift your shoes? Can you tie your, can you put on the belt of your trouser? Can you button your shirts? Can you comb your hair? So we begin to return them to their normal activities. So these are actually the issues we're trying to talk about when we say we need to restore back our activities. So please, ladies and gentlemen, we must believe that your rehab is not complete if you have not been able to make sure that the individual goes back to their normal activity. Of course, when we are trying to do return to activity, we should be able to monitor for any signs of pain, dysfunction, so that if there's need to adjust our program, we'll do that. So don't feel because you're now bringing back return to activity, you may not be able to aggravate some symptoms. So you must be very watchful in trying to go to the bra, especially during external rotation, that you're challenging the rotator cuff muscles, especially what do you call it? We'll talk about the sixth muscle, supraspinatus, and then the what do you call the teres minor muscle, where the rotation takes place, external rotation takes place. So these are activities that we need to do to ensure that our rehab process is complete. Now, please, I want us to look at a case study. The case is of Mr. John Smith. Mr. John Smith is 45 years old. He's an office worker, and of course, he is a recreational tennis player. In his medical history, Mr. John has no any significant medical history. He's a non-smoker. He doesn't smoke, but he occasionally uses alcohol. The major complaint he presented with was shoulder pain, which has been persistent, and then weakness of the shoulder, especially whenever he wants to do an overhead activity, such as playing the tennis from above or lifting an object. He mentioned that his pain was gradual at onset, which continues for over several months, with a noticeable increase in pain after he had a recent fall while playing tennis. He described his pain as aching pain in the shoulder, which has been exacerbated by lifting or reaching above to pick up something from the wardrobe. Of course, whenever you sleep on that shoulder, that is on the affected side, the pain gets exacerbated. After our full patient history and then the detailed account, we understood that he has used some over-the-counter medication and the rest that gives him relief. But presently, he still has slight swelling, tenderness, reduced range of motion, of course, in both anterior and posterior activities. Here, the question I want to ask us is for us to interact. Using the treatment principle, please, I want each of us, when you want to speak, you tell me which principle you want to talk about. So which principle are you going to be working on to treat Mr. John completely? Yes, please. Colleagues, can you hear me? Colleagues, are we there?
Yes, please.
Aha. So please, did you get my case study I posted?
Yes, I got it very, very well and clearly.
Yes, other colleagues, can we all hear? Is the audio clear?
Yes, sir, it's clear.
It is very
Thank
clear.
you. So we can
can hear
also
you,
see the
sir.
case posted there on the slide.
Sure, we can see the slide. We can see it.
Okay, please, the question, the activity I want us to do is looking at the principle of treatment of musculoskeletal disorder I have mentioned before now. I want you to choose which principle do you want to talk about. In this case, I have put on the slide.
Hello.
Yes, please.
Good afternoon.
Good
I will use
afternoon.
the
Is
principle.
that Mr. Harry coming up?
Yes, I'll use the principle of acute, managing in an acute way, acute for now, because of the signs of inflammation that is there.
Hold on, Mr. Harry, hold on. We want to understand which principle are you picking? Which one?
The acute phase. I still believe that the patient is in the
About the
acute.
application protocol. That's not one of the principles we talked about.
Okay. Sorry, I wasn't following so well. I thought it's
yes. So
okay,
we want us to follow that principle and then work on this. So it will give me the belief that in each kind of MSD you meet, you have understood this principle and you know how you want to tailor your treatment to the problem. Yes, please. Colleagues, I have almost 100 persons in this group and I need people to talk. Can we just feel free? There's no correct or wrong answers.
I can try, Prof. All right. I think I can go.
Kisilo, you're back.
Yes.
Okay, please go ahead. Which principle are you
I would
picking
use
up?
the principle of I would use the principle of restoration of mobility.
Okay, you want to talk about the principle of restoration of mobility in this patient. So tell me, what do you want to do about Mr. Jones' issue?
All right. So I believe that because of the lesion that in the shoulder joint, some of the articular structures, including the capsules and whatever, might go to what I call protective guarding. And therefore,
okay, so we're talking about spasms.
Yes.
Okay.
So I would want, after the pain management, to at least restore mobility within the shoulder, and also understand the state of the dynamic stabilizers, which in our case is the four muscles of the rotator cuff. So are they performing their role well in terms of the required flexibility, and also the ones that are important in stabilizing some movements that he has pain in, for example, the overhead reaching, sleeping on that side and whatever.
Mr. Kisilu, sorry, Mr. Kisilu, what I want you to do is to look at the case presentation you have in terms of the problems he has with the range of motion, and tell us what type of treatment will you tailor to take care of those problems. Because you have picked out the issue of, you want to use the principle of restoration of mobility, which is one of the key principles in the treatment of MSDs. So, but I want you to place that side by side with the concerns. So I want you to take from the history or the case we presented, these are the problems where he has issues that have affected his range of motion. And this is where we're going to be using this restoration of mobility using A, B, C, D. So please, I want you to put that so that everybody can understand clearly.
Okay. So I will first of all have a baseline in terms of the range of motion, the available range that this man could be able to do. And then on the range, or rather the R1, the point that the movements meet restriction and pain, I would have intervention specifically to increase the range of motion, just as we said in the restoration of mobility, and also enhance pain-free movement. Therefore, one of the interventions would be shoulder mobilizations. For the case of overhead lifting, that takes more of posterior anterior mobilizations, or rather AP mobilizations, lateral glides, and also most importantly, range of motion exercises of the shoulder with free or rather gravity, gravity being used without any weight.
Yes.
Yeah.
Yes. Well, I want to thank you so much, Mr. Akisilo. I appreciate that you have been following the program and then the presentation. But at the same time, I'm sorry, we from the academia, no matter what you do, we want to place your mark vis-a-vis the marking scheme. Okay? So sometimes you're like, how did I get this mark? But of course, this is not a classroom mark. Okay, it's about appreciating how do we place the treatment to fall within the problem the patient is presenting with. We want you to tally the problem to link exactly with the treatment. Now, do I have someone else want to speak about the restoration of mobility, the principle about restoration of mobility? Is anybody speaking about that? I want us to look at the case very well. Yes, colleagues, I wanted us to finish this by 4 so that we can all go back and enjoy the rest of the day. Please feel free to speak out. Like I said, there are no right or wrong answers. It's just about appreciating how you understand what we've been discussing. Yes, please.
Hello.
Yes, Mr. Harry, thank you. You're welcome back. Go ahead.
Okay, what I want to do would be restoration of activity. Since he's an office worker and also a tennis player, he would be very concerned about like occupational rehabilitation. So first of all, the pain must be released. Maybe the principle of rest, intermittent compression and elevation and all bandaging also, at least to rest it, because I think it's still in the acute phase. I guess it's still in the acute phase. So
No, then you see, that is where I've been asking us to read the case properly. If we had read the case properly, we would know that this patient has moved out of the acute, the subacute is now in a chronic phase.
Okay.
Yes, Abimbola sent a message on the chat, and she said she was going to be using the principle of pain management. Of course, that's one of the key principles, number one in any MSD, to take care of the pain. If you look at this patient, what brought him to the hospital in the first place was the persistent pain on the shoulder, okay? And he has described the pain as aching pain in the shoulder. Yes, and therefore that pain needs to be taken care of. The pain is something that is germane that we have to do. Now for Mr. Mr. Harry that spoke, we want you to see that the issue has to be with the issue has to be with the use of relating the present situation of his pain with the duration. And now if you look at his condition, is no longer at the acute or subacute phase, you will see that you need to put all your management, your exercise and restoration in terms of the chronic level, the chronic phase of rehabilitation. Okay, so please, that's the reason why I've been saying we must pay attention to where the problem is. That is the major point where we'll be dealing with which rehabilitation phase is this individual. After picking the principle you want to use, then you find out which rehabilitation phase is this individual, in which you have to link your principle with the protocol of the phase of that rehabilitation. Please, ladies and gentlemen, this is the reason why we are here today, to understand, because it's not about teaching you the exercise or which exercise or what treatment you're going to do. No, it's about tailoring the treatment to the problem, vis-a-vis understanding where, when, and how to do it. So this is why we want us to read the case carefully and then tailor the treatment to what? To the problem. One of the major problems of this case of Mr. John Smith was that he has this problem of aching pain, especially when he wants to do any activity that is overhead, you know, and that activity overhead, now that he's coming with pain, has been stopping him from his hobbies. And there are a lot of things he cannot do in terms of lifting objects. So if you look at all these principles, you will identify at which principle you want to take care of what from this case. Please, I want us to still look at it properly and see what we want to talk about in this situation. Please look at the case again. Colleagues, please look at it. Don't worry, just feel free. Any person can speak. If you have been able to link what you want to say to us.
Hello, good afternoon. Well done, Prof. Yes, hello, sir. Yes, I want to say that since the patient is having pain whenever he's trying to do any overhead activities.
Yes.
So I want to focus my attention on the superior, what's it called? The muscle, the rotator cuff muscle. The one on top, guys.
Forget about the impairment or anatomical structure that has been distorted. We want you to look at which principle of treatment are you wanting to pay attention now. Among the 4 or 5 principles we have mentioned, which one do you want to take and tell us about it in this case? I'm just trying to ensure that we all understand linking the principle with the condition in terms of treatment, so that our treatments are always going to be tailored and they are easy to follow.
Okay.
Colleagues, I do hope you understand where I'm going to. I hope I'm not confusing us the more.
Okay, Prof, I can do a trial now, eh? Hello, hope you can hear me.
Yes, please go ahead.
Yes, okay, so still on the principle of restoration of mobility, having gone through this case, that this patient is facing pain during executing the normal range of motion of the shoulder through activities. So I would have tailored exercise in the chronic phase to achieve progressive loading and with more focus now.
Sorry, Kisiwi. Are you now talking about the principle of return to activity or the principle of restoration of mobility?
I'm talking about the principle of restoration of mobility.
Okay, beautiful. Please link it and to the chronic phase you are talking about, and let's know what you're going to be doing there.
Okay. So after linking it with the fact that this patient is in the chronic phase, I would want to follow the pyramid of rehabilitation and enhance flexibility in the soft tissues that are limited. Also, number 2, I would want to introduce strengthening exercises for the same tissues that might be presenting weakness in firing, because all these movements, sorry?
I said that's beautiful. Those are the things we're talking about.
Yeah, thank you so much. So, because I believe these movements of overhead lifting, sleeping on the affected side, all of them requires the soft tissue to have some default muscle power to be able to withstand the execution of ADLs with that shoulder. So that is what I would do. Thank you.
Very correct. Very correct. Thank you so much, Kasewi. Well, I just hope, it's my hope that you guys are following, that we're trying to tailor the problem we want to solve with each of the principle of treatment. We don't want to put it at a whole lump and then we're not understanding what we're doing. So please, here we say the patient is already at a chronic phase of rehab. And when we're talking about restoration of mobility, we know it starts with stretches exercise, strengthening exercise, we go to functional training and all that. When we're talking about chronic phase, it is a phase where already we know that this patient has had shortening, tightness, a lack of activities and all that. So we want to restore all that, which will have to come using some manual therapy technique, strengthening technique, and all that. So please, this is what we're trying to gain at this point. I want us to move further because we're running behind time. Let me show you some of the activities I have put together for you. Now, we mentioned it has reduction both in abduction and external rotation. We noticed that when we did our strength training, there's weakness in the shoulder. Some of our special tests are all positive, like the MT count test, the NEARS test, the Hawking kinetics test. All these, I believe, perhaps we'll have mentioned it in the morning session. So all these tests are indicative of a rotator cuff pathology. A rotator cuff, some of the things we can use is an ultrasound. Ultrasound can show you if there is a tear of the rotator cuff muscle. Of course, MRI is very costly, and then we may not be able to afford it for most of our patients. And then clinically, you'll be able to judge if there's a tear or not with that. But an ultrasound imaging is enough, then you don't have to do an MRI for confirmation. Now, one of the things we created is our treatment plan. The treatment plan, we start with the principle of pain management. And now the pain management, we say we're going to have most different types of our modalities. Well, because there's a point where in that case we mentioned that the patient is still having some swelling. So if you have looked at it properly, you will notice that there is a, we talked about swelling somewhere in the joint. So that swelling, I said there's slight swelling and tenderness in the shoulder. Now, because of the tenderness and swelling, we will introduce cryotherapy at that point, whether it is acute or not acute. But because you can have exacerbation that will create an acute situation in a chronic state. So you must understand how to differentiate all that. And that's why I said in the pain management of this individual, we apply ice to reduce the inflammation and pain, and then we'll follow by a heat therapy to promote blood flow and healing. Do we agree with this pattern I put together? Does everybody have a different opinion? Why should I use ice in a chronic state?
No, I would prefer ice because of the swelling, but I will not subscribe to the fact that we should use it because it will provoke more of a prostaglandin and some other P factors. They will come into.
I said we should use ice to reduce inflammation and pain, and then follow by heat. So
I won't follow it by.
I won't follow it by heat.
I won't want to follow by it at all. I won't want to follow by it.
What we mean by following by heat is not immediately you are removing cryo and you'll be putting heat. We're saying the moment the inflammation has subsided, you can still use heat on that individual.
That should be contrasting. Would that not be contrasting?
No, it is not contrasting. Look, what you're dealing with is acute exacerbation in a chronic situation.
Okay.
If you follow the case, if you follow the case carefully, you realize that he said this pain has been there for over 7 months. Okay. All right. And we said there's still also, we could use some NSAIDs. It means you can still use some anti-inflammatory drugs to take care of that situation. Now, in the principle of restoration of mobility, we mentioned we're going to do some stretching, which involve passive range of motion exercise to maintain flexibility without overloading the injured tendon. It is going to be free weight. The individual will move the hand within a pain-free region, without resistance. So this is what you'll be doing until you're able to build the muscles above that. So I think with that, we'll be able to know the level where the patient is before we move ahead again. Yes. Now, there is also the issue where we talk about the gentle static stretches, targeting the shoulder girdle muscles. So all these are exercises you want to introduce gradually as the pain reduces. You're trying to increase the range of motion to an acceptable level without the pain. Of course, we'll also introduce manual therapy, which will be about soft tissue massage to reduce the muscle tension around the shoulder. We're going to do joint mobilization techniques where you start with isometric, then the isometric shoulder exercise to maintain the muscle activation without stressing the tendon. We progress to resistance exercises where we'll gradually introduce resistance band for shoulder abduction. So you can just use the band where she can match on the band and then she abducts the hand using the match. She's matching on the TheraBand and then using the upper side to pull. So all that will progress with that. We can use that TheraBand in different angle of motion, whether the abduction, external rotation, internal rotation. We can also move into weight training, like using lateral raises or rows with light weight. So gradually improving the weight that you'll be taking. Eventually, we'll return the individual into functional exercise that will simulate their daily activities, such as reaching and lifting. So such exercises like, lifting the hand above the head. So all these are exercises that may help the individual to return back to activity. The individual we mentioned, he plays recreational tennis. Then we'll begin to teach him sport-specific drills for tennis, so that we'll be able to restore his confidence and then performance in an overhead activity. Talked about the balance and proprioception, where the exercises will enhance shoulder stability, such as standing on one leg while performing a shoulder movement. All these are activities to enhance the patient. Of course, the education and self-management is also part of the principle, where we want to do an ergonomics, we advise on proper posture, adjustment of the workstation, so that there will be avoidance of strain on the shoulder. Recently, most of our patients that are using phones, some people who don't understand that they've been carrying their phone and chatting for a long time. That could put pressure on either the shoulder or the neck. So all these, we have to educate them properly about that. And of course, we should be able to customize a home exercise program that will reinforce what we have done in the clinic, and of course, to ensure continuity of this of the care. At home, when there is pain, we can always instruct our patient to use ice or gradual heat, using the heat water bottle for gradual home pain management. Ladies and gentlemen, this is one of a clear clinical case that we will do our using the principle of treatment of MSD. I cannot pick one specific MSD. I'm just bringing this at random. I'm going to put up another case. Let's say a case of low back pain. This is the rehabilitation protocol that I've mentioned about the patient from week 1 to week 6. What do we want to do? This is what you do between week 1 to week 2, which is on pain management, gentle mobilization. We use ice application, NSAID, and the range of motion exercise. In our subacute phase, we try to introduce active range of motion and all that, resistance training with band, and then chronic phase, then this is what we did. Then to return to activity, which is after 3 months and above, we try to return back this Mr. John Smith into tennis and other overhead activity. Of course, we monitor for signs of pain or dysfunction, adjusting the program as much as it will be needed. Of course, we should also talk about how do we monitor our outcome. You know, we must talk about our outcome, because when you are managing this patient, we should have what we call the objective outcome measures. Now, if I want to measure pain, what should I have used in measuring pain? You know, there are a lot of pain scales that you can use.
Numerical pain rating scale.
What did you say?
Numerical pain rating scale.
Okay, the NMRS, right? So
yes,
why
sir.
did you choose that over VAS? Why did you choose the NMRS over VAS? Dr. Bukola, do you feel it's just, well, you want to just use the MPRS and then it's okay? There's no choice? Why is one better than the other? Of course, they're all valid, they're all reliable. What about the ease of administration? Between MPRS and VAS, which one is much easier to administer?
VAS.
Are you sure? In our day-to-day clinical activity, which is much easier. I'm not really, you know, you guys are not making me, I mean, you're not pulling me out. I want people to talk.
Okay, according to me, bro.
Yes, Mr. Kisilu.
You can hear me? Yes.
What?
So according to me,
yes.
According to my context, visual analog
Yes.
scale is more objective than numerical pain rating scale in our context.
So is it the objectivity you are looking there, or at the ease of administration?
Sometimes, yes.
Because you see, every pain scale is subjective. But you just try to see that there's a level of objectivity inside the subjective nature of pain scales. Now, when you draw the line, the 10 centimeter scale, you know, and this is how you measure it, the same way is what you mentioned when you're discussing with your patient or client about the pain the numeric pain scale. You know, the numeric pain rating scale is just to tell the patient 0 is your most minimal pain you have, means there's no pain, and 10 is the highest pain you have ever felt. Between 0 and 10, where do you think your pain lies? Presently, for instance. Now, I'm drawing a ruler, okay, from here to here is 0 to 10 centimeters. Wherever you drop your pain, this is where your pain lies, we measure it. But don't you think some patient with poor, what do you call it, cognitive issues are not likely to understand your ruler than the explanation? You get my point?
Yes, sir.
So, Bukola, which one will you choose to use?
Like you explained that the numerical written skill.
Well, they're all reliable, they're all valid. So whatever one you want to use is just the ease of the usage you will use. So it's fine. Well, just because of time, I'm going to go to the second case. It's a case of chronic low back pain. Because after addressing the patient, we've been able to identify all the contributing factors. You know, we've mentioned how you should do your assessment, your evaluation, you know, you should be able to collect all this information that will help you manage the pain properly. So I give you this case of a patient with low back pain. The pain has been there for the past 8 months. The pain does not allow the patient to walk for a very long time. The pain is more whenever he is seated in doing an activity. The physical examination has shown that he has poor flexibility, reduced back strength, and a lot of reduction in functional movement. Okay, so and then his X-rays and MRI were able to identify that the patient has multiple level decompression. So I want you to also use your the principle of restoration of musculoskeletal disorder in managing this patient. So can somebody tell me, what would you want to do? How do you tailor the problem to the treatment? Yes, please. Let's quickly discuss this. We have like 15 minutes more so that we can go for today. Colleagues, please feel free to speak. You know, it's more interesting if we're participating.
Okay, I can come in again, eh?
Mr. Kisilu, I want to pick someone else. Yes, I'm
Okay,
sorry,
thank
I'll
you.
come back to you. Let me pick somebody else.
All right.
Yes. Omidire Bolade, are you there? I have my guy is in this group. Dr. Blessing Jonathan, this is not fair. You now left me, I'm just shouting and shouting.
My Oga at the top. When you were talking about a lady, I was the one that wanted to talk. Now you said I should not talk. Now you want a meal. So now.
And now I'm captive, so you have to say something. So
What
let's
will
see
I
how do we
say?
get about the patient with back pain into our principles of treating musculoskeletal disorder vis-a-vis the rehabilitation protocol. So please, can you go ahead?
Wow.
No, don't,
Sure,
it's not because we have talked about it. Just use your director sense.
I think what we want to do is just to bring the patient back to function and also to ensure that we strengthen the muscles and ensure that there's mobility. If I don't know if I'm right. I think, but if I have a patient.
No, you are right. You are very
patient,
correct. What I'm just expecting all of us to understand this evening is this. Whenever you have your patient with MSD, of course, we have been, they have discussed how we should evaluate, assess, and then, you know, examine your patient. Now, the whole essence of your evaluation and assessment is to highlight the major problems this individual is bringing to the clinic.
Yeah.
All right. So we now say there's a principle you will use to take care of all these problems. One of the major principles is what? We say the principle of pain management.
Yeah.
So the condition is already low back pain. So it means I should be able to manage pain first.
Yes, it's true.
So if I'm now looking at this patient, what is the level? I will measure this pain and then understand where is the pain. What are the things we could do to take care of this pain? All right. And we have talked about all our modalities. And we talked about incorporating, you know, our medical colleagues in trying to understand or take care of the pain. So it means we could also use medications at some point.
Right?
Yeah. Now, I haven't talked about that. we said we should be able to see during pain management, we should tailor it to the phase of the rehabilitation. Now, is this pain we are managing, is it at the acute phase? At acute phase, it's about what? Reducing inflammation, you know, reducing the pain sensitization. And we talked about the modalities we would use to do that.
Talked about
so this is what we are trying to do so that we don't get ourselves confused. The second principle in when we're talking about MSD rehab treatment, we say it is what? Restoration of mobility. Okay? So which vis-a-vis is the function. Now, when trying to restore mobility, we say we're going to start by what? Gradual stretching exercises, strengthening exercises, and functional rehabilitation. Where we begin to mimic most of the exercises that will bring about our activities for daily living. I hope we're moving together.
Yes, very good.
Then the third one is when we talk about return to sport or return to activity. All right?
Yeah.
We said we'll be talking about return to activity. And now this activity now, this activity we're trying to talk about is activities that will help the individual to go back to what she or she was used to doing prior to the affectation. Now, I haven't talked about the restoration of activity. We now mentioned the last goal, or the last one is about, education and self-management. This is another key point, which is germane into our principle. We need to educate the individual about the problem, how to prevent further exacerbation, how to prevent further occurrence or recurrence of the problem, and then how to take care of themselves by themselves. We try to do this by teaching them the contributing factors into their problem, like ergonomics, okay? And then how to take care of themselves, self or home management program. So all these are things we have talked about. Ladies and gentlemen, I hope I will still not be shouting in vain, because this one I catch my organ, so there's going to be a problem. All right. So do any person want to add to our discussion for today? We're coming to a close of this session. We have about 5 minutes. I really want to open it up for questions and answers. You know,
I wanted
in my
to say
case, I
something.
mentioned that core stabilization, manual therapy, and all that. Yes. Any other thing you want to talk about? Please feel free. Feel free.
Hello, sir. I wanted to ask a question.
Please, ma'am, go ahead.
Sir, I just wanted to ask, do we have impact on diets? Because I hear recently that the kind of food people take actually would affect their kind of pain as well.
Exactly.
And if they are going through issues in their marriages, or if they are having emotional issues, it has a way of affecting their pain. So I just wanted the clearance.
These are very, very practical and real situations. It's before now, we don't understand that even some type of food we eat they are pro-inflammatory diets. And what we mean by pro-inflammatory, it means usually you have a problem which is a pain as a result of inflammation. Now the food you're eating, especially most of this junk food that we buy at the eateries, talking about meat pie, pizza, all this bullshit, the canned drinks and all that, they are pro-inflammatory in nature. Most of them contain these ingredients that are going to enhance inflammation. So when you eat some type of food, you will notice that your pain increases. So those are pro-inflammatory, and which nobody will be able to identify rather than the patient. The patient must understand what he or she does eat themselves that aggravates their pain. So these, they must be able to take care of it. At the same time, you understand that whenever you can go through chronic pain, it disturbs your quality of life. Not only that, it affects your relationship between you and your spouse or the family. Now, a woman who is going through some depression and the husband decided to also ignore her, the pain of that man ignoring the wife in terms of this situation is going to cause more flare-ups, more problems. But when she have more supportive husband, more supporting children, or more supportive family, she tends to see her pain as being mild and controllable. So all these have been shown in researches that they really impact on how we process pain. If you look at pain education. So please, we should know that these things are really, they are real and that they are affecting our patient. We should be able to handle it as soon as they come in. Thank you so much.
Okay.
Any other
Thank you, sir.
situation? Yes.
I want to just say one more thing. Thank you very much, sir. First of all, okay. First of all, when I saw your name and Professor Mukadas, I said, no, I have to attend. These are my organs, my family. Thank you so much for this is not what I was expecting. I was expecting the normal, manipulate, do like this. This is coming, this is Oyibo standard, and I'm very thankful to you. I know you schooled abroad, and I know you have good taste for good things. Thank you so much, sir. I want to say that of recent, I started doing some presentation on self-care, and I'm going to be presenting in SSPN in Benin, SSPN, yes, Pain Society. And my topic is self-care in pain management. Like it's a paradigm shift, and that's exactly what you're saying. And I want to thank you. I learned a lot, and I'm very grateful that I attended. God bless you, sir. God bless you. Thank you so much. Thank you.
Thank you so much. My Ogash is there. She's getting all the feedback. So I'm getting a new promotion. Dr. Blessing, the director, you are not running away.
When we finish the class, I'll call you.
Colleagues, kindly feel free, please, to just discuss. You can open up for discussion.
Hello,
yes, please,
Prof.
go ahead.
Hello, sir.
Hello, can you hear me, Prof?
Yes, I can hear you. Go ahead.
Oh,
sorry, people are raising their hands. Alani, I've seen you. Oluwatope, Sharafa. Okay, we'll pick one after the other. I think Alani is on the ground now.
Thank you.
Speaking?
Exactly. Thank you so much, Prof. It's been a while. I'm happy to hear you today again. Thanks for your wonderful discussion so far. We really appreciate you. On the concept of returning to activity, as you did mention, I think that is usually affected by so many factors as physio. From my own point of view, you made mention that rehab is not fully completed when the individual is not able to return to what his or her baseline was. I think there are so many factors that can actually affect someone to actually achieve his or her baseline. We talk about comorbidity, how frail the individual is, and age.
Yes.
For the physios who deal with the elderly, this is commonly seen. A patient in his or her 80s or 90s who has been walking properly without aids will tell you after rehab, well, I think I can actually walk again, but I wouldn't want to try that without a stick. You know what I mean?
That's right. Yes, that's right.
So I think I will want us to look at this in two ways. In as much as I want to go by that rehab is not fully complete if an individual is not back into his or her baseline, I think what the patient goals are is as important as that. If a patient tells you, yes, I want to walk again, but I think at this stage, I can't just do that on my own without a stick, even though I wasn't using stick prior to now, I think we should accept that. I don't know if you get my point.
Exactly. I got you clearly and loud and clear. I
Thank
think
you so much.
it's something that is not open to debate, and it's just a way of misconception of that argument. When we talk about return to activity, it means return to activity, to the most highly independent stage. So it depends on what best can you do. We're not saying you should go back to your pre-motor state.
Thank you for that clarification. Thank you so much.
Yes, I think that's
Thanks so much, sir. Thank you so much, sir.
We still have some few minutes. Yes, can you go ahead?
Okay. Good afternoon, ma. Thank you
Good
so
afternoon.
much for the.
It's not a mao. I don't know how my voice is
Good
not.
afternoon,
It
sir.
doesn't want to be a sir. I don't want to hear a mao.
Sorry, sir. Good afternoon, sir. Okay, my question is: you have a patient.
Yes.
After your assessment, she has low back pain. She has osteoarthritis.
Yes. So what do you want to ask about that? Or did we miss her? Oh, where are you there? I think we missed her. You can still come back. Let's take
she was better. She could walk normally. She goes back home.
Sorry,
Same
we
thing.
lost you
I
a
keep
bit.
educating her, but
Hello,
no treatment.
Hold
Hello,
on.
sir.
We lost you a bit. Yes, we lost you for a while. We would appreciate if you could just go back and tell us everything you want to talk about.
Okay, I said you assessed the patient. It happens that the patient has low back pain and osteoarthritis bilaterally. After the whole treatment, she walked.
OA of where?
The knee.
OA spine or the OA knee? Okay, both knees.
Both knee.
All right.
So after treatment, she was better.
Okay.
She goes back home. She comes back again with that same pain. You treat her, educate her. She goes back again. She still comes back after like a month. She still consists of the same thing. She still works the same work. But after each treatment, she becomes better. So it's like kind of frustrating to me. I wanted to tell her because she's a geriatric patient and she kept on complaining. But after my whole treatment, she'll be better. Let her just go home and come back a day after like this. She comes back again with the same plane, with the same mode of movement. So I'm like just kind of tired. I wanted to say, Mama, please stop calling. So I just want your personal input.
I'm going to send you to see which of my guy just finished speaking now. You know, he's working with the geriatrics. So I think we will have to also put you how to work with the geriatrics. Okay?
Okay, sir.
It's something that I think you're still not doing properly, which you have to do. Now you notice that your patient, whenever she comes to the clinic, she gets better, she does something good. It means there's a problem between the house and her coming to clinic.
You need to
so it means you need to evaluate what is happening. I just told you a case of a patient that we had to follow him into his car to now identify it is the car sitting posture in the car that was giving him the problem. So you're not supposed to get frustrated. You're supposed to identify the problem. Okay? So please, I urge you to evaluate the mama further. Maybe given some instances at home. Mama, how is your bed? How do you sit? It's possible she still sits in the very couch outside her house. It's possible there's a lot. Maybe mama still bent down to sweep and all that. So you need to find out further.
And sir, we can also find out if mama is receiving extra treatment like local masseurs. Sometimes these elderly people get their house help for people in the house to start massaging them, and sometimes they injure them or they take upward position or something.
Sorry, some people have just opened their mic and they are the bus stop. So please mute yourself if you are still not at home. All right. There is DB. DB, please go ahead.
Finished, Prof. I finished speaking. I don't know whether you heard me.
Okay, thank you so much. Your voice was breaking up when you were talking.
Okay,
so
I said that aside from what you said, which is very correct, like there are some that you have to follow to their business places. Maybe she's sitting too long. or probably she has
Exactly.
someone who comes in, like is not really an official caregiver, but the person comes to assist her. That person may be massaging a part of the body, maybe doing something.
And in
They may
fact,
be positioning her in a
very
bag.
practicable and possible scenario of having a problem. Thank you so much for that.
Thank you, sir.
So,
Yes, sir.
I believe you must have had something that you will add
Yes,
into your
yes, sir.
recipes. Okay?
Yes, I'll into that. Thank you, sir.
You're welcome. DB, please go ahead. Your name is
Yeah.
shown as DB. I hope you.
Yes.
Go
Good
ahead.
afternoon, sir.
Good afternoon. You are welcome on board.
Yes, sir. Thank you very much for a very great presentation, sir.
Yeah.
Earlier in the presentation, you talked about radicular pain and radiculopathy, and you said those two are different. I wouldn't mind if you could quickly go through both of them and what their differences are.
I'm going to refer you to the Abuja people. I just had a workshop in, I think at the end of May in Abuja about managing low back pain, and we did that very well. So I will send you to go and buy the screen, the presentation there, okay? So the Abuja people can make more money from you.
Or you could just spend 1 or 2 minutes to just talk about it, sir.
Yes, the major difference is that radiculopathy doesn't come with pain. Radiculopathy is those sensations, either motor, okay, either motor or sensory affectation that comes with a nerve compression. That's radiculopathy. Talking about paresthesia, numbness, and all those sensations are the things you call radiculopathy.
Tingling sensation.
Hello, who is at the bus stop that is not allowing us to hear what now? Okay, DB, are you following me?
Yes, sir, I'm following you, sir.
So I said radiculopathy as those sensations that could be either sensory or motor affectation that comes with a compression of a nerve. Do you understand?
Okay,
I gave
sir.
an example. I said paresthesia, numbness. These are all
Tingling
radiculopathy
sensation.
or weakness of a muscle. Now you have a radicular pain. It is that pain that follows a nerve root. The pain that, paresthesia is not a pain. I hope you understand that. Those are sensations.
Sir, I do.
But pain that comes with following the course of a nerve is what you call a radicular pain. I hope that's clear.
Yes, sir.
If you're
I
still
got
being
that. Thank you very much,
confused,
sir.
the radiculopathy, it is a sensation which is either sensory or motor. So sensory in terms of paresthesia and numbness, those are sensory. Then the motor one is when you have weakness of that limb following a compression somewhere. That's radiculopathy. But radicular pain doesn't have to come with your sensation or weakness. I hope you understand.
Yes, sir, I do, sir.
Okay, thank you so much. Kisilu, I said I was going to take you back. Yes, please, Kisilu, go ahead.
Thank you so much, Professor Bello. I thought it's good to speak. I'm not from the Nigeria context, but
We
I can
all
admit.
understand that.
Hello?
Yes, we're hearing you.
Yes, I would want to admit you guys are amazing. I'm very humbled. I'm just conveying gratitude to all of you. Your presentation and the fact concord with our context on this other side, because the whole goal is to make patients better in this world. And I want to appreciate you for that amazing presentation. I'm also a colleague, but more in a specialist in neurorehabilitation. And just to add on and make my colleagues know what we are doing on this other side, we are trying to come up with trends on addressing neuroplastic changes that come up with chronic pains, especially in the lower back pain. So we are looking at the brain on matters neuro, and it is amazing to see also you guys also working to achieve the common goals that was envisioned by WHO.
Yeah,
Thank you so much.
that's a wonderful one, and we really appreciate you joining us. From your accent, we all know that that's not Nigerian accent. Our Nigerian, when we speak, people think we are quarreling. Hey.
Yes. I'm a girlfriend to Nigeria. May God bless you.
Yeah, thank you so much. Are you from Ghana?
I'm from Kenya.
Kenya, all right. We're very happy for you to be with us today. We appreciate you too. Thank you so much. My Oga Sunday, I know you are there, but I thought you decided to be quiet today. I know. Please, I will give you 1 minute for us to wrap up.
Okay, thank you, sir. I just want to actually appreciate you for this presentation. It has been so robust and very explicit enough for us to understand. And actually, I was a little bit lost at a point, but later I was able to join again. And the areas I actually met in the area of questions and explanation you are given. I just want to probably shift in. There are some areas where we're explaining about radicular pain and where numbness is not even regarded as pain. But then when you look at some of those presentations at the neurological level, you will discover that most of, even when numbness occurs at a particular limb, it could advance in the progressive way if it's not properly good. It could equally, in an advanced stage, leading to radicular pain because a progressive compression of a particular lumbar spine areas which will predispose a patient presenting with numbness. If it is continuous in that level, it could equally advance to radicular pain. So there are sequence and a progressive generation taking place at that moment. So most times, numbness should not actually be looked down because it could advance to a level whereby the patient may begin to have weakness even at the lower limbs. So that I just want us to have this background. They say again, somebody asked earlier concerning a patient she handled and the patient keep on coming, after coming, then relief and all that. I want to look at it from the perspective that when you look at that kind of patient, being a geriatric patient, most times you discover that a lot of them, we want to have one, home intervention that appears that are not actually in the realms of physiotherapy, field. So most of the time, the tendency of even injuring them more. And when they have such a severe pain, it's when now they return to physiotherapy. But then I think we can have holistic examination about this patient, asking some conject questions to as regards to what is the cause, just as Dr. Blessing Jonathan was trying to explain a little the other time, that what are those predisposing factors that are actually making the patient to be coming off and on. Now, a duration of time, what is the interval that the patient actually return to the physiotherapy to receive treatment? What interval? So that all those areas too should be questioned. Because if the patient comes after 3 months, after receiving your treatment and gets better and return and coming back to after 3 months, a geriatric patient, the likelihood of predisposing them to other further degenerative conditions is very high, and the tendency of returning back to may be equally high. Those are the areas of my contribution, sir. Thank you very much.
Thank you so much, Mr. Sunday. We appreciate you. The major point we're trying to pass across is for our young colleagues to understand that we should not mix it up, that radicular pain is the same as radiculopathy. Of course, you have mentioned that it could progress to one leading to the other. It's possible, but at every point in time is to find out what it is, as at when you are asking the question, because there's no any objective measure for those things, all right? And of course, for the other young lady, you could hear from her voice of frustration as a naive and a novice physiotherapist, which is and getting this kind of feedback was already giving her concern. And of course, we told her one of the major things is to just go back, go into evaluating some of the patient home equipment or ergonomics that are likely to predispose her to that, because she's worried that the patient comes to her, she's fine, she goes back home, and that's where the problem is. So we want to believe there could be some other issues in the home that is not making her treatment, because what she wants to see is that sustainability of the treatment. She doesn't want to be like, okay, you've taken a paracetamol and now your pain is gone, but the primary problem is still there. When you go back after the half-life of the paracetamol has decayed, you come back with another, that the pain is back again. And that's why she's worried. So we're looking at it that, okay, we believe the problem could still be from the home and so many things other colleagues have mentioned. So we're just gonna add yours or perspective into the recipe so that you can look at that mama in a holistic way. So we thank you guys very well. I appreciate you all for coming, and I hope we'll be able to meet some other time to discuss further. I thank you guys for giving me the opportunity to also learn from you. It has been a wonderful moment, and I hope I can wrap it up at this point. Our colleagues, have a wonderful evening. Thank you so much.
Prof, well done.
Okay,
Thank you, sir.
so much.
Thank you so much. Thank you so much.
For the wonderful presentation. And we thank all the participants also for this participation. And the whole month will be for orthopedics. So next week we should have another session which will focus majorly on radiological principles in musculoskeletal conditions. So hoping to see you again next week. If there are any comments or any concern, you can reach us via our email.
Thank you very much.
Yes.
All right.
You're turning on the part.
Okay, ending Dala. Okay, ending.
Thank you, sir.
No, if you go to make a, you know, one day.
The thing from start, you have to be tracing back to.
And that's what they do.
When you remove that rather than do that. So you have you go up.
Don't do your leg. Bend your leg like someone walk. Very good. When you take a leg,
Hello.
Every time. You must win. So tell ask him, will you win first? No, I don't. Then we have not finished till he say he wants to win. Are you ready? Are you ready? So now what I want to wait. Your time are very busy. I see you. You walk inside. You maintain inside the door. Whenever you want to cross the line. Let me show you what that is. Are you seeing? Are you seeing it? So you go like this, like this. When you not, you won't do like this. You will do like this. You must be inside the door. Exactly. Remember, if you can't be if you are you let start it will be like this. So this will not be your midnight. So you don't have to do inside. 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 Just in the leg. As I said, this is too much. The temptation. Don't let go cross. Complete now. Cross it. Cross down. Like your leg inside. Correct. But and